Good morning, ladies and gentlemen. It is my pleasure to welcome you all to this special program on dengue, critical challenges in dengue care, lessons towards zero deaths, organized by the National Dengue Control Unit in collaboration with the Ceylon College of Physicians and the Sri Lanka College of Internal Medicine. Today's program comes at a particularly important time as Sri Lanka continues to witness a rise in dengue cases across the country. Today's discussions, therefore, address not only a timely topic, but also a pressing public health priority. We hope that the insights shared by our distinguished speakers today will further strengthen our collective efforts toward achieving zero dengue-related deaths. We are delighted to have with us today an esteemed panel of clinicians and healthcare professionals committed to improving dengue care and reducing preventable mortality in Sri Lanka. Without further delay, I would like to invite Professor Namal Vijayasinghe, President of Ceylon College of Physicians, to deliver the welcome address. Over to you, sir.
Good morning, ladies and gentlemen. Dr. Kapila Kannangara, the Director of National Dengue Control Unit. My senior consultants, my teachers, my colleagues, ladies and gentlemen, good morning. First of all, I welcome you to this very important workshop. We conduct this both on site as well as this is streaming live to 17 other places. So I welcome our online participants also. As you all know, it's very important to have this workshop today, as the topic itself explains the critical challenges how we should face in the care of dengue patients and trying to achieve the number of zero deaths. You know that already this year we have had 30 deaths by this morning in the country, as well as more than 50,000 cases diagnosed, and 10,000 of them in the Western province itself. And I was told that the hospital admissions have gone up by 1,000 cases per day just because of dengue patients. So with that in mind, the Ceylon College of Physicians decided to partner with the National Dengue Control Unit. First of all, I must thank Dr. Kapila Kannangara and his team to agreeing to collaborate with us, as well as Sri Lanka College of Internal Medicine, Dr. Madhuvanti Hettiarachchi and the Council of the Internal College of Medicine to collaborate with us to organize this program. I also thank the esteemed speakers today, Dr. Anand Wijevikrama, Professor Anuradha Dasanayaka, Dr. Damayanti Dampitiya. They are experts in the country in the dengue care, as well as I must especially thank Dr. Dumita Govindapala, who is the real strength behind organizing these events together with the National Dengue Control Unit other members. So while thanking them, I welcome you again, and I invite you to get the maximum benefit from this program. Thank you very much.
Thank you very much, sir. Established in 2005, the National Dengue Control Unit has played a pivotal role in coordinating Sri Lanka's efforts to prevent and control dengue through surveillance, vector management, capacity building, and strengthening clinical care. Its sustained commitment has contributed significantly to mitigating the impact of dengue and improving patient outcomes across the country. Today's program is a testament to that commitment, bringing together the National Dengue Control Unit in collaboration with the Ceylon College of Physicians, the country's oldest and foremost professional body dedicated to advancing healthcare, and the Sri Lanka College of Internal Medicine. To continue the proceedings, it is my pleasure to invite Dr. Kapila Kannangara, Director of the National Dengue Control Unit, to address the gathering. Over to you, sir.
Good morning, everyone. It will be a brief talk by me. So I'm representing the National Dengue Control Unit. I'm so thankful to the Ceylon College of Physicians for coming forward at this critical juncture to do this workshop today. And I'm so thankful to Dr. Dumita Govindapala for she's behind all this, as Professor Namal said, and thank you very much, madam. And also for the eminent speakers who are here today, Dr. Ananda Vijayavikrama, Professor Anuradha Dasanayaka, and Dr. Inampitiya. So it's a pleasure and a privilege to be here speaking to you a few words. You know that today, and also big welcome to all the eminent specialists, the senior registrars, SHOs, MOs, everyone here. We are going through a very serious outbreak these days since, it started about 3 weeks ago. And we are doing, in public health, we are trying to manage the outbreak as much as possible. But as you know, due to a lot of challenges, it has become a very difficult task in doing so. But obviously, the Ministry of Health, the Honorable Minister, the Secretary, the Director General are all with us in this endeavor. So we have been sort of coordinating with all the provinces, the regional directors and the MOHs in trying to work out a lot of programs on the field at the grassroots levels to minimize. It's simply about us giving a lot of opportunities for the mosquito. So that has been the real problem, because the nature has not been that kind on that aspect, because there has been continuous rain. And other than the other years, we've compared the years, we have started 2026 with a higher baseline, because after the Ditwa, as you know, there were a lot of, the waste disposal was in tatters, and even the local government found it very, very challenging to clear out the places. So there were a lot of breeding sites lying around in the country, mainly in the areas where it was flooded. And this gave rise to the baseline. In January 2026, it was much more than what it was for the last 5 years. So we had to continue from there. So suddenly this came up with the rains. As you know, the dengue has two peaks with goes along with the two monsoons. And now generally it's a time where it peaks now, but then this is a sort of exponential rise in the numbers. So it's very timely that this workshop was held. As you know, yesterday there was a workshop in Matara, which attracted a lot of interest, and before that in Ratnapura. So, and today I hear that also it has created a lot of interest amongst the clinicians, and we are, I think, transmitting it online to about 16 hospitals. So there are so many people now, the clinicians who are, on this program today. So thank you very much again for the eminent speakers today, and all the other eminent consultants and the SRs and the SHOs who are here today, physically joining this program, as well as people who are online joining. And hope you will have a very fruitful time, and it's a pleasure to coordinate with the Ceylon College of Physicians in doing this. So we hope to continue this kind of programs in the future as well, which makes it, worthwhile. Thank you very much.
Thank you very much, sir. Our first lecture for the day is Alarming Vital Signs in Dengue, Red Flags You Should Never Miss, which will be delivered by Dr. Ananda Vijayvikrama, Senior Lecturer in the Department of Medicine, Faculty of Medicine, University of Muratua. He has been a pioneering figure in advancing dengue management in Sri Lanka, playing a key role in introducing the current dengue management practices to the country. He currently serves as the chairperson of the National Dengue Management Guideline Committee and has mentored and trained numerous postgraduate trainees over the years. It is a privilege to invite Dr. Ananda Vijayvikrama to deliver this lecture. Over to you, sir.
Good morning. What I'm planning to do is today to discuss few cases, the actual patients, to see where things went wrong and where things could have been addressed and probably turn the progression of that illness in these patients, so that we can understand what happens in these patients, especially when they have serious problems. Now, before starting on that, I must say one of the problems we see in dengue is probably the major problem we see in dengue is that most of them recover without any problem. Why I say there's a problem is when that happens, sometimes we think what we do is correct and applicable for everybody. In majority of the patients we see, they have either dengue fever or dengue hemorrhagic fever without much leaking. They have some leaking, but the leaking is not very, leaking is probably little. So they recover on their own. Whatever we do, they recover on their own. However, when it comes to a patient who is having significant leaking, then it is different. Or leaking with bleeding or with bleeding. So these are the people who needs different approaches from the normal management of a dengue fever patient or patient with mild leak. Let's see this patient. This is a 56-year-old male, a farmer, has come. This is a presentation actually prepared by medicine registrars in medicine in their training program. And I have added few questions so that we can discuss this in detail. This was made based on the BHT. And so this patient was admitted on 6th of February with a fever for 2 days. On admission, his platelet count was 169 and NS1 positive, pulse rate 54, blood pressure 110/80, and other parameters are normal. This was on 6th of February. And on 8th midnight, that is on day 4 midnight, his platelet count has gone down to 81,000 and hematocrit remains same. Next day morning, the platelet count, white count has gone up to 5. Platelet count has gone down to 75,000 and hematocrit has increased to 40.3. They were not measuring the PCV, but they were doing regular full blood counts because there had been a problem in the hematocrit machine. So at 8 o'clock, when this count is received, what action could be taken? Continue IV fluids. These are different sort of things of questions. So now if we go back, we know the patient's platelet count has crossed 100,000. White count is going up. So this is the time a patient can leak. And also, in addition to that, we see a rise of PCV from 34.6 to 40.3. So there is about 16-17% PCV rise, which is suggestive of plasma leak. So this is the time, if we can do a leaking scan. Even without doing a leaking scan, if it is not possible, it's always worth taking this patient into the critical phase chart, because with this PCV rise, considering the other circumstances, is most probably this patient is leaking. So scan was done at 9 o'clock and leaking was detected. And they did another blood count at 10 o'clock, which showed a PCV has further gone up a little So now it is about 20% rise, which confirms leaking even without the ultrasound scan. So these at 10 o'clock, midnight platelet count was 81,000. So they have taken the critical phase, back the critical phase by 10 hours. And taken from 12 o'clock, midnight, maybe a little earlier, maybe it started a little earlier. But I think this is a fairly reasonable guess of timing of the critical phase. So the next issue is, now what are you going to do to his fluid? How much fluid you are going to give? Is otherwise stable, output is okay, pulse rate, heart, blood pressure, those remain stable. Any guesses from our registrars? I may have discussed this with some of the registrars in their program. Now, generally, we give 100 ml for these patients to maintain their normal usual losses, which are the urine output and the insensible loss. Now, here, there's an additional loss by the way of plasma leakage. So, we need to give additional fluid in addition to the maintenance fluid, because there's an additional loss. Right? It is like if the patient is vomiting, we have to give more fluid, or if the patient is having significant diarrhea, we have to give more fluid. It is the same principle. So, we need to give more fluid. So, I would increase the fluid to about 150 or so and continue that for a few hours and see. However, they continued with 100 ml power, and the PCV went up to 42 by 5 p.m. and the output, the heart rate, you can see the heart rate, the blood pressure and the urine output, you can see. And by 7 o'clock, the output has reduced. You can see there's a gradual reduction of urine output, and by 6 to 7, it had been reduced to 20 ml for that hour. At 5 p.m., PCV 20% and 42, that is 20% rise. So now, if one sees this patient, so this is the what happened to the patient, and if you see this patient at 5 o'clock, or so rather 7 o'clock, what would you do? Increase the fluid intake, dextran, blood transfusion, reduce the fluid intake, IV furosemide. Now the issue is the urine output is going down. So if you give IV furosemide, of course the output will improve, but then the intravascular volume will deplete, and that will lead to endless problems. So that's not, we cannot do that. And we cannot reduce the fluid because now the patient is reaching the peak of the critical phase. PCV is high, there's no indication for blood transfusion. Generally, we try to avoid dextran in the first half of the critical phase. So dextran is not the option, but we need to increase the fluid because now the leaking is becoming more and more prominent. Now this leaking when the leaking starts, in some patients there's some leaking, and then leaking occurs at a sort of a more or less of a flat rate. So that's a small amount. They had a small amount of leaking. We don't have to do much adjustments in the fluid. Anyway, they recover. But in some people, the leaking progresses. So that's where we have this sort of problems. We see this sort of changes. So what they did was they increased the intake to 120 ml power, and the output improved. And then after 4 hours, they cut down the intake to 75 ml. This is the end of the first half, 24 hours. At 12 midnight, another PCV was done, and the PCV has gone up to 46.1. Platelet count is going down further, which is expected, and white count is going up. So these are the other parameters are here. So if you see this patient at this end of this point with a PCV of 46, what should be done? This is a 30% rise of PCV. These are the parameters. Now, generally, when we see a 30% rise of PCV, we consider this as similar to shock. Because if the patient is not in shock, the patient is very likely to go into shock very soon. So, this is a condition where we have to treat as shock, which means the patient needs a fluid bolus 500 ml over 1 hour for an adult. However, the output had been okay. They continued with 75 ml, then later they increased the 200 ml power. And you can see the PCV went up to 45 and then 41.9, the hematocrit. And this is the output, and you can see the other parameters. So now the critical phase is over. Nothing happened. And I was telling you that I would give increase the fluid at the middle of when the leaking was detected, and at 24 hours I would give a bolus and so on. But those were not given and nothing happened. So what's the problem? So is it what we are sort of preaching is wrong, or this at midnight, 12 o'clock. Next day morning, patient was complaining of shortness of breath, and patient was tachypneic and tachycardic. Blood pressure under nerve okay. Output has gone down, and patient is desaturating. So if you see this patient at this point, what immediate investigations would be the most useful investigations? Of course, we need to do all these investigations. But for the immediate thing, I think the PCV and the venous blood gas are the immediately needed and usable things, because those results will be available within few minutes. We need to do the blood count, LFTI and RAS. Yeah, of course, you have to send blood, but we need to do the venous blood. So, the physician VP saw this patient at 8 o'clock, and then he identified the problem, and then he thought it's better to put this patient to ICU, so he called us. So then I asked whether he has done a venous blood gas. He said yes, and this is the venous blood gas. Other reports available later. pH was 7.1, lactate was 8.4. So why is he having this deterioration? Now by end of the critical phase, patient was given 4,800 something fluid. So that's very little more than this thing. So not fluid overload, but we saw how the fluid was given. Except for 4 hours where fluid dose increased to 120, fluid dose basically given at a flat rate and not considering the way of leaking. Of course, patient may be having some pneumonia, septic shock, but the most likely reason is the hypovolemia causing acute liver injury because the fluid was not given according to the rate and amount of leaking. So this is what can happen when the patient is given fluid like this. So anyway, now we had to do something to the patient. So he said, okay, we'll take over the patient. Now what is to be done pending the transfer? Now this transfer is going to take maybe 2.5 to 3 hours. Now this period at this time when the patient is critical in a very critical condition, basically patient is in shock, the few hours matters. So we need to tell what to do during the before transferring and during the transfer. And there are two main problems here in this patient at this time. One thing is patient is acidotic and lactatemic because of the acute liver injury. and acute liver injury is due to reduced intravascular volume. And the acute liver injury will precipitate bleeding. So we need to correct the volume. That's the most important thing. So whether to give dextran, blood, of course, no place for furosemide, normal saline. Now the patient is towards the end of the critical phase, hypovolemic, intravascularly. So we need to correct the intravascular volume as much as possible and as soon as possible. So I thought giving a dextran bolus would be the best thing so that it will get the extravasated fluid back into the intravascular compartment. When we give a dextran 500 ml, intravascular volume will increase by maybe 1500 or even 2000 ml. So that will be at least to some extent, that will address the problem. And then when it comes to this level, these patients bleed. So what I told him was transfer the patient as soon as possible and start the dextran pending the transfer. And if there's a delay in sending, give a blood after the dextran or start the blood on the way. So they arranged the transfer very quickly. The dextran was given, and on the way in the ambulance, they started the blood. So the patient came here like this. This is the dextran and after the blood. But even then, in spite of that, when the patient came here, patient was still acidotic. This is the blood gas we did at NIID. Still acidotic, it was high. So we intubated the patient, ventilated, another dextran was given, more blood was given. So since that time, it was blood, then FFP and dextran. He was, then he went into AKI, so we had to dialyze him. Actually, we dialyzed our nephrologist, Chanaka dialyzed him quite early, which we thought was very good. And so he was dialyzed, had 6 cycles of hemodialysis, and several blood transfusions were given. He was ventilated, intubated for 6 days and ventilated, and then finally recovered. But this was a narrow shave. I was not sure whether he would survive. We were not sure. Everybody got together and discussed in detail what to do. And then we faced this problem, and still we were not sure whether the patient would survive or not, because it was such a critical condition. So the patient was lucky. So looking back, so the physician, who is a friend of mine, called me and asked later, so what was the error they did? So I said, you have given fluid at a flat rate and you didn't increase the fluid. So I said, he said he didn't increase the fluid because the patient's urine output was okay. I said, but his PCV was regularly going up. Then he said, a couple of years back, his child was admitted with dengue, and catheter එක මිරිකල අන්තිම බිඳුවට වෙනකන් ගත්තාම 0.5 ml තියෙන fluid වැඩි කරන්න ඕනේ නැහැ කියලා තමයි manage කර කියලා. So that was he was following. So anyway, I thought your child would have had very mild leaking, luckily. So it's not so when the leaking is more. So that's the problem. And then when we were discussing this with our registrars, one of them showed something which I didn't notice actually initially. Now this patient is a farmer, quite a fit person, healthy person, and his baseline on admission heart rate was in 50s, 54. You can see his heart rate has gone up. So this is the importance of using the chart. You can see what had been happening over the hours, rather than taking only a cross section. From 50 to 54, it had gone up to 80s and 86. So he has actually become tachycardic. So these features are important to notice: the gradually rising pre-CV, tachycardia, developing tachycardia. So even though other parameters are normal, when this happens, we have to realize that there is significant leaking. But because he's a fit person, he tolerated all this for 48 hours. But then there's a limit. If this happens to a 50-year-old diabetic patient, before 48 hours, the patient would go into shock and collapse. So I think he was different because he had been a very active person. Yeah, yesterday we had a program in Matara, again organized by the College of Physicians and Dengue Control Unit. And on the way, I had a call about a 17-year-old girl admitted on 22nd evening with a history of fever for 4 days. And platelet count on admission was 65,000 and hematocrit was 38. And ultrasound, there was no leaking. Was admitted in the evening. And then early morning, her output has dropped. They have increased the fluid. And then they did the ultrasound in the morning, which showed leaking. So they took the patient into the critical phase chart. And this is how they have given the fluid. Since they have detected the leaking in the morning and back this thing by 6 hours, but probably I think she would have been leaking probably for 12 hours or even more. Because the patient's platelet count of 65,000 on admission, so probably even though the leaking was not detected on admission, probably patient had been in the critical phase. So the fluid had been increased and then the output has picked up and then again the fluid has been cut down to baseline, the maintenance fluid. Again, the output went down, again the patient has more fluid. And then this was the time they contact the dust. Again, the output had been, you can see the output had been actually going down. And the PCV done at 4 a.m. was 4. So what to do? So now, most probably the patient is in the latter part of the critical phase. Even here, patient is in the second half of the critical phase, but most likely it's probably more than that. Maybe it started maybe another 8-10 hours before they have marked. They have decided. So patient is in the latter part of the critical phase, and patient has had 4,900 ml of fluid during this period where they have taken that is from 1 o'clock in the morning. So now the patient is becoming the oliguric, and the obvious reason is the intravascular volume depletion. So we need to correct the volume. Now we have given fair amount of fluid, so the correction of volume should be now by giving dextran. Right? So I said, give a dextran and give a blood. So the VP asked me, why blood? Her output is so, even though the output has gone down, there is no tachycardia. The blood pressure is normal. So I said, so the best way to convince him was, I said, you give the blood, do a PCV. If it has gone down below the baseline, then give blood. Give a dextran, do a PCV. So then he called after the giving dextran, then the PCV has gone down to 29. So then the packed red cell was given and the PCV went up to 36, output improved. And then we cut down the fluid to 50 ml power. After that, oral 50 ml power. And in the morning, the physician called me and said the patient is now okay. Now, why blood in this patient? Damayanti will discuss this in more detail. But because I had this case yesterday, you can see this patient, when she came, her PCV was 38. Probably patient was leaking, even though this didn't show. Now, in a dehydrated patient, the leaking may not be detected in the ultrasound scan. Leaking may not be obvious, right? But when the patient is having fluid, leaking will become more apparent. You can see here the PCV is 35, and in spite of patient becoming oliguric, there was no PCV rise. So in addition to plasma leakage in this patient, we can reasonably assume that there is occult bleeding. So that's why I said to give a blood without any hesitation. But that was substantiated by the fact that the dropping of the PCV with dextran. So other issue we see here is the way of giving fluid. Now when the fluid is given, now if we assume this duration of critical phase, taking the critical phase is correct, you can see the fluid had been cut down to the baseline in the middle of the ascending phase. So this time patient is leaking. So we can't cut down this, and that sort of thing will lead to volume depletion and affect the liver, and of course increase bleeding. Right. Let's look at another patient, again an actual patient who was later again transferred to NIID. This again prepared by registrars, the presentation. 28-year-old male, previously healthy, and he was admitted with a history of 3 days fever. So it's probably the 4th day, with a platelet count of 35,000 and hematocrit of 39.9. Was afebrile on admission, had a pulse rate of 106, blood pressure was 100/60, NS1 positive, and on the admission they did a leaking scan which showed plasma leakage. So where do you think the patient is in the critical phase? Day 4 of fever, you have completed 3 days, day 4 of fever, and platelet count is 35,000, ultrasound shows leaking. So since it is day 4, most probably I would say it is still probably in the ascending limb of the critical phase. However, since the platelet count is quite low, he is probably towards the middle of the critical phase now. So the second question is, how much fluid you would give to this patient on admission? Now, of course, he is leaking, so he needs more fluid than the maintenance fluid. Then the volume we have to decide based on other factors, like how much fluid he had been taking before coming to the hospital, whether he had been having other losses like vomiting, loose motion. If so, if he had those additional losses, then we have to compensate for those also. If he had been taking enough fluid, now sometimes the GP might have advised to take 100 ml per hour, which he had been following. So in that case, he had his hydration, otherwise his site maintenance was okay. So we need to address the fluid loss as the leaking. But if there had been additional losses, we have to give more fluid. So I would start the patient empirically with either 200 ml or 250 ml on admission and give that for 2-3 hours and see how the patient is. Because now the patient is towards I would say, consider this patient as going towards the middle of the critical phase. So if the patient had been having reasonable amount of fluid at home, then I would start with 200 ml, or one might say one would start with 300 ml. That is okay. Well, whatever, this patient needs more fluid because the patient is leaking. They started the fluid with 75 ml. And the chart you can see patient had been monitored quite well, and except for the fact the heart rate had been put only in the first 3 hours. I don't know why, but after that the heart rate has not been included in the chart. Maybe the patient was connected to the monitor. And the patient's output had been okay, and you can see the blood pressure. So if somebody sees this patient at this point, now they mention the heart rate. Capillary fill time less than 2, heart rate is 116, blood pressure is 106/56, respiratory rate 22, and patient had been passing adequate amount of urine. What would they do? obviously the patient is becoming unstable. Patient has become tachycardic. Of course, on admission also, patient was tachycardic. And we saw that the patient is leaking and the patient was given fluid at a flat rate. So by now, patient is bound to have problems. If the patient is not in shock, patient will be in shock in few hours. That's what I would have thought. So if I see this patient at this point, I would give a fluid bolus, be 500 ml even. And then, depending on the PCV readings, to decide whether to give blood and how to continue other fluid. However, the patient was continued on a flat rate of fluid, 75 ml per hour, and then later it was increased to 100 ml. Now the critical phase is over. Patient is passing enough urine, and only problem is the patient is tachycardic, and on a couple of occasions you can see the blood pressure has gone down. But the patient is okay. Now we thought the critical phase probably started, probably by this time patient is in the middle of the critical phase, towards the middle of the critical phase. So by now, end of this, definitely the patient is beyond the critical phase. So fluid was given like this, and except for tachycardia, nothing happened. Next day morning, the patient was complaining of abdominal pain. And then he was sent for a ultrasound scan around 12 o'clock, midday, and after to the radiology department. After coming from that, the patient collapsed. So we got a call around 3:30 in the afternoon saying there's a patient like this, whether we can take over the patient. Then I asked again whether they have got a blood gas. They said yes, and this is the blood gas. First blood gas showed pH of 7.09. So I said they need to intubate and ventilate this patient immediately. So then he said, we have already intubated the patient, and they were looking for ICU bed. So we said, okay, we'll take over the patient. And you can see here the PCVs had been mentioned here. PCV 39.9, 45, 46, 52, and 38 later. This 38 may be after they didn't have dextran at that time. They have given hetastarch, maybe following that. But the PCV had gone up to 52. Now his baseline PCV was 34. Sorry, 39. So 52 means again more than 30% rise. So when the patient came to us around 6:30 in the evening, and my ICU MO WhatsApp me these two charts. So I got really annoyed, and I called back the VP and said, this patient is going to die. We will not be able to save this patient. So then he asked why. So I said, you are given fluid at flat rate, and that's why the patient is in shock now. Then he said, අපි අනිත් ලෙඩුන්ටත් මෙහෙම තමයි ෆ්ලුයිඩ් දුන්නේ, නමුත් මේ වගේක් මීට කලින් වෙලා නැහැ. Exact words. So this why I said at the beginning, most of these patients recover without any problem, because either they have only dengue fever or they have mild leak, so they recover. And that doesn't mean that can be what we did for those patients can be applicable to this sort of patients. So I said, but these patients have been tachycardic and PCVs have gone up. Then he said, when he saw the patient in the morning, patient was okay, patient was talking, there was no problem. So what do you think he didn't do in the morning? He has spoken to the patient, seen the patient, spoken to the patient. What do you think he didn't do in the morning? I don't think he touched the patient. Because if he touched the patient, you can't miss a heart rate like this of 130. So sometimes one problem we see is the patient is connected to the monitor, and we look at only the monitor and rely only on those things. Of course, the tachycardia would have been there if the patient was connected to the monitor. But one thing we cannot rely completely on monitor. This monitor says the blood pressure, especially when they have when they are decompensating and unstable. Sometimes the monitors show or readings may not be very reliable. So always we advise nurses and junior doctors to check the blood pressure manually from time to time. Not always, at least from time to time, check it manually. And of course, we need to see, of course, if you feel the pulse, you know whether the volume is good and heart rate and the peripheries, you can detect all those. So we tried a lot, but unfortunately, this patient died. We couldn't save him. Because if a patient had been given fluid like that throughout the critical phase to a patient who is having significant leaking, that patient is going to die whatever we do after that. It's too late to address this problem. Right? Because from the beginning itself, patient had been tachycardic, which means patient was decompensated. So it's much too late when we got this patient. So when we see these patients, especially patients who have died, we see some, even though the deaths are not common, even in these patients who die, we see some common problems, even though the deaths are not common. One thing is not increase in the fluid in leaking patient. And when we ask why the fluid was not increased, often the answer is urine output had been okay, or the blood pressure had been okay. But one has to realize that here we give the maintenance to maintain the insensible loss and the urine output. Here there's an additional loss. So that is the exact reason to increase the fluid. So what we, in the guideline, what the guideline says is increase the fluid gradually, and then in the second half you reduce the fluid. You can reduce the fluid. And we do not recommend flat fluid rate with intermittent boluses. Now that is what was done before 2010, when we didn't have guidelines, when we didn't realize exactly what is not happening. So if we increase the fluid, we have to gradually reduce it and maintain a reasonable amount of fluid during this period. And then another problem we see is, as in this patient, no action, not taking action when one parameter is abnormal. So the heart rate is rapid, but no action was taken because the output was okay. So some patients can have normal output, especially these days. We see many patients who are having not only normal output, sometimes polyuric, in spite of having leaking. I don't know how to explain that, but that was a very unusual finding we saw earlier. It was rare, but now I don't know whether because of the more patients, we see it commonly. Patients, in spite of leaking, having more than normal urine output. And then another common problem is not identifying bleeding. Damayanti is going to address some of the issues there. And one has to remember is the bleeding is mostly occult. And don't wait to see blood or try to confirm bleeding by doing unnecessary procedures like occult blood, because bleeding is not only into the gut, can be due to anywhere, can be to anywhere. So one has to take decisions especially of giving blood based on the PCV and clinical parameters. So that's what I thought of discussing today. So once all presentations are over, we can discuss other issues and problems. Thank you.
Thank you very much, sir, for that insightful presentation. We will now move on to our next session, titled Hematocrit and Blood Transfusion in Dengue, When Delay Can Lead to Death, which will be delivered by Dr. Damayanti Idampitiya, consultant physician at the National Institute of Infectious Diseases and a member of the National Dengue Management Guideline Committee. Dr. Idampitiya has contributed immensely to dengue care and has been actively involved in postgraduate training and capacity building in the field. Madam, the floor is yours.
So my topic today is hematocrit and blood transfusion when delay can be dangerous. We'll start with numbers. So these are the deaths occurred in 2024, 2025 and 2026 as of last week. So as you can see, more females than males. 2024, 20 females, 4 males. 2025, 17 females, 12 males. And 2026, 6 males and 22 females. And you can see the age ranges. So majority of patients are in between 25 to 45 age group, as you can see. But this year you can see more elderly people are dying because of dengue. So this is 2024 death analysis. As you can see, that is 4 males and 20 females, total 24. So the number, if we take the number reported, more males than females, and the CFR is males, it's 0.01, and females is 0.093. So CFR of females is 6.6 times higher than males. So clinical teams treated for fluid leakage but failed to recognize concealed internal bleeding. Delayed blood transfusions occur almost 50%. So we'll move on to the case histories. So this patient is a 30-year-old previously healthy male. He had fever, arthalgia and myalgia since 6th of May. He got admitted to a local hospital on 8th. So that is the 3rd day of the illness. And on the same day, he was transferred to a bigger hospital. And so he was managed there. On 12th, he was detected as having leaking. That was the day 7 of the illness. So at the same time, they have taken the patient to the critical charge from the time of detection of leaking. So on that day, his platelet count was 14,000. Ultrasound scan showed leaking. And he had tachycardia, ECG showed sinus tachycardia, and troponin I was marginally positive. So they were managing this patient as dengue hemorrhagic fever complicated with myocarditis. So the patient got himself discharged from that hospital and got admitted to our hospital. After 5 hours of journey, he hired a private ambulance and came to our hospital at 5:30 p.m. So we managed to get his counts which were done at the previous hospital. So the first count was done at the local hospital. That was on the 3rd day of the illness morning. Platelet count was 121, hematocrit of 40, and the WBC of 2.89. Then the patient was transferred to the big hospital where in the evening they have repeated the count. WBC was 2.42, platelet 108, same hematocrit. STLTs were okay. Then the next day, day 4 of the illness, WBC 2.05 with the platelet 103 and the platelet hematocrit of 40. And the 5th day of the illness, platelet count was 97,000, hematocrit of 39, the same like 40, and the STLT is rising a bit. Then the 11th, so that was the 6th day of the illness, platelet count was 71,000. Hematocrit has gone up to almost 43. Platelet has dropped down to 71. And the day of admission to our hospital. So this is what they have done, not from our hospital. WBC has gone up to 3.61. Platelet 14,000. PCV 35, and STLT 1,424 and 698. Right. So this patient was leaking, detected on the 7th day of the illness with the platelet count of 14,000. So when do you think this patient has entered into the critical phase? Is it day 3, day 4, day 5, day 6 or day 7? So they have taken it as day 7. Probably this is the time it crosses the 100,000 mark, and the next day you can see the rise of PCVs. So probably that's the day 5 of the illness. He has entered into the critical phase. So day 6, the peak, and day 7, probably towards the end of the critical phase. That's why the platelets are that low. And the day 7 of the illness and fever free. So this is the chart. To be more clear, I put it into a graph. Anything you notice here? Any abnormality? Okay. There are several things. So patient was all right on 10th, 11th and 12th. What happens? You can see the tachycardia is developing. It's a sudden onset tachycardia. And the blood pressure had been all right, but you can see the blood pressure is dropping here. And urine output was quite good, but it is coming down now. Platelet count was 71,000. It has dropped down to 14,000. And the hematocrit 42.9. Now it has become 35. Right? Anything you want to consider at this moment? Bleeding. Yes, very good. Because patient is now becoming unstable with falling of hematocrit. Most probably this patient is bleeding. Right? And it has gone up probably due to leaking here, and then it's coming down because of the bleeding. You can see the patient is becoming unstable with dropping of PCV, hematocrit. So on admission to our hospital, he was complaining of dizziness and backache, ill looking, sweating, cold peripheries, CRFT equal to 2, blood pressure 95 by 75 with the 20 pulse pressure, tachycardic 112, low volume pulse, right hypochondrial tenderness, PCV node was 36, bedside ultrasound scan shows leaking. So he was in shock on admission to our hospital. So blood gas on admission, lactate 2.9, AST 1540, ALT 770. Actually the platelets are rising, hematocrit 35. So what we have done, we have given a half dextran, and afterwards PCV dropped down to 32. Output was not very good, so we gave one blood transfusion here. So you can see the pulse rate dropping a bit, but still patient was not that good. CRFT was prolonged, tachycardic, output was marginal. So and there was no PCV rise at all. Right? So usually after blood transfusion, how much PCV do we expect to, like how much PCV rise do we expect? It's around 3 to 5, right? So there's no rise at all. So we thought of ongoing bleeding. So we gave the other second blood as well, which stabilized the patient. Right? So after that patient was stable, pulse rate dropped down, output improved, CRFT became less than 2, and the blood pressure picked up. So among his complaints, he was complaining of a backache and dizziness. Right? So he was having a very severe kind of backache. So we did the CT scan to show psoas hematoma. Right? You can see this, the psoas, two psoas muscles either side. And this side, this is a normal psoas, and this is the hematoma. And you can see the enlarged muscle. So this is not the best cut. I have selected but anyway, you can see the enlarged psoas muscle. So, so here now, what we have to consider is bleeding can be concealed, right? You may not see bleeding at all the time, but you have to think of bleeding into muscles and bleeding, internal bleeding, if the PCV is dropping and patient is becoming unstable. So the next case. So this one is a 17-year-old girl admitted to a hospital on 23rd at 4 p.m. Her complaints on admission, fever for 3 days, and arthralgia, myalgia, headache, nausea, vomiting, usual features of dengue. There was no postural dizziness. Urine output normal. She was menstruating, but it was a normal period. So, what do you think about this patient? Is she in the febrile phase, critical phase, or convalescent? What phase do you think? Probably febrile phase, because there's no evidence to say the patient is in the critical phase from the history. because it was the third day of the illness, and there was no postural dizziness, urine output normal. So we can consider it as the febrile phase. So examination, patient was afebrile and ill-looking. Pulse rate was okay, 88, good volume. Blood pressure okay, 110/70, lungs clear, no abdominal tenderness. So they have scent count as well as NS1 antigen. Monitor the intake and output from 7 p.m. to 7 a.m. Intake 800, output 500. Anything abnormal you notice here? Are you happy with this patient? Anything you spot here? Ill-looking, very good. Afebrile and ill-looking. Right? So if a patient is becoming afebrile, if it is just dengue fever, patient should recover, cannot be ill-looking. Right? If the patient is afebrile and ill-looking, it is one of the warning signs. If patient's general condition deteriorate with settling of fever, you have to consider leaking in this patient. Right? Okay. So the next day morning, 8 a.m., blood pressure 80/60, tachycardic. That's the time they trace the reports which was done at last evening, that's 23rd at 4 p.m. WBC 1.8, hematocrit 40, platelet 70,000. Dengue NS1 antigen was positive. Right? And so they diagnosed dengue shock. So repeated the count. It showed platelet of 36,000 with hematocrit of 40. And they have started the critical phase from 12 midnight, 8 hours back from the time of shock. Ultrasound scan showed evidence of leaking. So this is the way they have managed this patient. So I'll just give a couple of seconds to go through this chart and to find out whether there's any abnormality, any problem in management. Okay, first of all, timing of critical phase. Is it correct? 12 hours back from the time of shock. It has to be almost 18 to 24 hours, right? Platelet count was around, that day morning count was around 36,000. Right? So if the patient goes into shock at 8 a.m. today, then patient should enter into the critical phase around 8 a.m. yesterday, right? So patient is getting admitted at 4 p.m. At that point, we showed the patient, the platelet count was 70,000. That was the previous day count. Even though the patient was hemodynamically all right, we saw a patient who was afebrile and ill-looking, which is an indicator that the patient has entered into the critical phase, right? So at 4 p.m., now when you are looking back, you can see the patient is in the critical phase on admission to the hospital. So that's one thing. And they have given a fluid bolus. Yes, agreed. And then there's something here. Patient was sent for ultrasound scan. Do you need an ultrasound scan at this point? What is important, ultrasound scan or fluids? Fluids, very good. So fluid is more important than the scan here, because in the scan you are going to see leaking, nothing much. So they have sent the patient to the scan room without giving any fluid. Then you can see very rapid cut down of fluids. So if the patient is in shock, you have to gradually cut down the fluid. Within 3 hours, patient's fluids was taken to the maintenance. And here they have given a dextran, half dextran within 1 hour. That is again wrong. If you are giving a half dextran, it has to be within half an hour. And here they have given a blood. Is this blood indicated? Now, do you think this blood is needed or not needed? PCV is 40, 39, 40. Anyone want to give a blood for this patient? So if a patient is now, we don't have her baseline, but we have the count which was done earlier. That was the previous day, afternoon. Their hematocrit was 40, right? So when the patient going down, on the next day morning, at the time of shock, again the PCV is 40, right? Which means, now if the patient is in shock, how much PCV rise do you expect? If it is compensated shock is 30%, decompensated shock 40%, profound shock 50% or more. So if the patient's baseline is around 40, when the patient is in shock, what should be the PCV? Should be 30% from the 40, that has to be around 52. But when the patient is in shock, PCV is around 40, which means patient is bleeding, right? So this blood is really needed, but this blood has to be given quite early, not at this point, right? And this blood is slow as well. They have taken 2.5 hours to 3 hours to give the blood. Actually, they have to give it quite fast because patient is leaking. If you go back to the history, she was menstruating even though it was a normal period. So she bled and bled and bled, right? So she was in shock the next day morning. Now what you can see is her pulse rate is increasing, right? And you can see the urine output. Initially it was a bit okay, marginal, but later on there was no urine output here. Here 5, 4, 2, urine output is dropping. So the next day, multi-organ failure, DIC, tachycardia, hypotension, bleeding plus, acidosis, gross ascites, bilateral pleural effusion, no urine output. Despite all the ICU interventions, patient passed away. So where did we go wrong here? One thing is we just ignored the afebrile and ill-looking patient. We just ignored the menstruating female, right? And then when the patient developed shock, we didn't pay the attention to the PCV, right? So if we think that the PCV is like baseline PCV is around 40, now the PCV is around 40, which means this is, anyway we know that the patient is leaking because ultrasound scan shows leaking. In addition, bleeding has to be there, otherwise PCV cannot be stable, right? If the patient is leaking, in shock and leaking on like purely due to leaking, we expect 30% rise of PCV, at least 30%. So which is not there, right? So the previous case, we showed PCV is dropping, right? So their initial PCV was around 35, but it went up and it dropped to 35 again. So it was dropping from the onset of critical phase, it was dropping and patient bled. PCV was dropping. But here you will see the PCV is stable, but patient is bleeding, right? So if the patient's PCV is stable and patient is in shock, we have to consider, okay? Third case, 22 years, female, admitted on 19th to tertiary care hospital. Her condition on admission was third day of the illness, arthralgia, myalgia, retroorbital pain, vomiting, 3 episodes. There was no loose motions, but she was complaining of dizziness, no bleeding manifestations. Her LRMP was 2 weeks ago. So, the only concern here is dizziness, but otherwise, third day of the illness, having symptoms of dengue. So we can consider it as the febrile phase. And so on examination, she was febrile, 52 kg of body weight, blood pressure was okay, 120/80, not tachycardic, good volume pulse, CRFT less than 2 seconds, lungs clear, abdomen not tender. Counts, WBC 3.7, hematocrit 35, platelet 192,000, creatinine and all the others were normal, except STLT is little bit high. Dengue NS1 antigen was not done, right? So here they have considered this as the febrile phase, started on febrile phase monitoring, right? That is acceptable. And 3-hourly monitoring, oral fluids were given 100 ml per hour, and patient was kept on the floor due to overcrowding. Next day, blood was not taken. Patient was missed as she was on the floor, so no counts available the following day. Then 21st, that was the 5th day of the illness. She fainted in the washroom. Then staff brought her to the bed, and she was complaining of dizziness, afebrile for 24 hours. She was tachycardic with 148 pulse rate, low volume. CRFT was more than 2 seconds. Blood pressure was low, 80/60. Urine output 75 ml for 5 hours. So she was in shock. Right? Then they have done the count. That was platelet 52,000, PCV 40, AST 1,306, ALT 758, point of care ultrasound, gallbladder wall edema, free fluid in hepatorenal pouch and pelvis, and small right-sided pleural effusion. They have done the blood gas, pH 7.34, lactate 7.4, and bicarb 15. So these are the 2 counts which they have done on 19th, 192 platelets with WBC 3.2 and the hematocrit of 35. And this is on 21st. That's the time patient was in shock, WBC 10.9, and the platelet count has dropped down to 53, and PCV has gone up to 40. So this is how they have managed this patient. 40 PCV, baseline 35. So they have given 2 fluid boluses. Here 1,700 means that's the previous day intake. And they have given 2 500 boluses. So ultimately here 2,700. Taken 24 hours back to the chart. They have given half dextran within half an hour here. And they have given some more fluids and the PCV 40, 35, 35. Here 75 and the output 75. Tachycardia still is there but is coming down, and the blood pressure is still low, 90/60. Here of course 80/60, and the output is a bit low. Right? So for the next hour, what do you want to give? IV fluids, dextran, blood, or any? What do you want to give for the next hour? Okay, right. So they have given a blood. Right? They have given a blood, and it showed PCV went up to 42, and then they transferred the patient to us because patient was still having tachycardia, and the output is towards low side, and the blood pressure was also bit towards low side. So once the patient came here, we gave dextran. And the PCV dropped from, when we received the patient, PCV was 45. And after the dextran, PCV was 32. Now, next hour, what fluid do you want to give? Normal saline, dextran, blood, oral fluids? Yes, right. So, you have to give a blood. Why? One thing is, patient is unstable, still not stable enough. Output is not picked up, still tachycardic, blood pressure even though is better than what it was, and you can see the drop of PCV 45 to 32. So the maximum drop of PCV after dextran will be, how much PCV drop we can expect after the dextran? 8 to 10. Right? So if the maximum drop, if there's a maximum drop, then again the PCV should be around 35. It dropped more than 10 points, as well as it dropped below the baseline, right? So she needs another blood transfusion. Okay, so she was given the second blood, and after that, patient clinically improved. Right? And you can see the tachycardia is settling, and the PCV went up to 35, 40, and here of course we have given a half dextran. Afterwards, patient was all right, changed to oral. Output was improving. Then patient became stable afterwards. So this patient, now on admission, can we think about bleeding in this patient? PCV has gone up. Baseline was 35. When the patient was in shock, it was 40. Right? PCV has gone up. But is there a 30% rise? No. Right? So if there's no 30% rise, now we know patient is leaking because our ultrasound is positive. So always consider bleeding in addition to leaking. So this, when you see this PCV of 40, you should know the patient is leaking, of course, yes, but in addition, patient may be bleeding. So when you give some fluids, you will see the PCV drop. And in addition, if you have a doubt, you can give the dextran and see how much PCV is dropping. Once you give the dextran, if there's more than 10-point drop, or if the PCV drops below the baseline, that means patient is bleeding. You have to give a blood transfusion. Right? Okay, right. Few things about the hematocrit critical phase. So the purple line is the critical phase. This is what happens during the critical phase. And the dotted line is PCV. What we expect, PCV to increases gradually and to reach the peak here. So that will be the maximum PCV rise as well. And then we expect PCV to drop like this and to become normal after 48 hours. But will this happen in the real world? There are many factors which contribute to this PCV, right? So, what are the things which contribute to the changes in PCV? During the febrile phase, if the patient is dehydrated, patient may be vomiting, having lot of diarrhea, not taking adequate amount of oral fluids, having high fever. So, all these things can lead to dehydration, which can increase the PCV a little bit. So, you might see patients who are on admission, even though the patient is in febrile phase, little bit high PCV, when you give fluids, it will come down to the baseline. Then during the time of leaking, the leaking itself increases the PCV gradually. Then during the critical phase, there can be bleeding, which will drop the PCV. And our treatment, fluids can reduce the PCV, dextran will markedly reduce the PCV, blood will increase the PCV. So depending on the amount of leaking, amount of bleeding and the treatment, the PCV can either go up or go down. And when it comes to the reabsorption phase, because of the reabsorption, hemodilution can occur and PCV will drop. So towards the end of the critical phase, because of reabsorption, there can be a reduction in PCV, even it can go below baseline, and then it will come back to the normal. And if patient enters into the equilibrium means there's like after the critical phase, we expect the patient to enter into the convalescent phase and reabsorption. But in some patients, this will not happen. There will be a period of equilibrium where there's no reabsorption. Reabsorption will be delayed, but leaking has stopped. Right? So, as there's no reabsorption, now there will be a period where there's no leaking and no reabsorption. So, the intravascular volume has to be stable. But it will not happen because patient is having insensible loss, patient is producing urine, we are giving a little bit of fluid. So, because of these things, the PCV can change here. Usually what happens, during the equilibrium period, there will be a slight rise of PCV. Right? That's why when sometimes you see, even after the critical phase, PCVs are not dropping as we expected. So this equilibrium phase can be there for around 3 hours, 4 hours, or it can go up to 24 hours or even more than that if the critical phase is eventful. Which means if patient goes into shock, or patient started bleeding, leaking, and lot of complications, then the patient will definitely enter into the equilibrium phase. That's why if there's a patient coming in shock, so that will be the peak of the leak, that patient will be having only 24 hours more to the critical phase, to end the critical phase. But now after that period, we expect the patient to recover. But usually patients will not recover just after 24 hours because patient has entered into the equilibrium phase. Right? So we don't have to act vigorously during this period because critical phase is over. If the patient's PCV is quite high, you can go for half dextran or a dextran, something like that. But you don't have to give any IV fluids here. If you give IV fluids, what will happen? During the time of reabsorption, so your vessels will be full and patient will end up in fluid overload. So factors which affect PCV value, we have discussed it earlier. So PCV can go up due to plasma leakage and blood transfusion and during the equilibrium. PCV will go down due to bleeding, reabsorption due to hemodilution, IV fluids and colloids. Then PCV can be stable, the leaking plus bleeding, leaking plus IV fluids, bleeding plus blood transfusion. So if the patient is leaking and bleeding, patient can be unstable with normal PCV as in the second case. And leaking plus IV fluids, sometimes we are giving a lot of IV fluids which can reduce the PCV. So there won't be any PCV rise. So PCV will be normal. And if the patient is bleeding and if we have given a blood to correct that, then the PCV can be normal. So the PCV can be markedly high in a patient who is leaking and dehydrated and in addition. So if we have not given adequate fluid to correct hydration, and in addition if the patient is leaking, PCV can go up to a very high levels. And if patient is leaking and if we have given unnecessary blood transfusion, again the PCV can go up to a really high values. Then the PCV can drop very significantly if patient is bleeding and if we are trying to correct it with IV crystalloids. Right? Sometimes patient is unstable without thinking of the hematocrit. We give lot of IV fluids which can drop the PCV markedly. And if a patient is bleeding and if we give colloids, as we discussed in this third case, you can see the PCV drop after the dextran. Sometimes if we are not sure whether this patient is bleeding or not, we give a dextran and see whether the PCV drop is more than the expected value. So then the question about PCV and hematocrit, which is better? So PCV is measured directly by centrifuging the blood, as all of you know. This is a PCV machine, the hematocrit machine, and we are physically measuring the proportion of packed red blood cells. Hematocrit values are usually lesser than manually checked PCV, as there is no trapped plasma in automated hematocrit calculation. When we are centrifuging the blood, there can be some plasma trapped in between the red cells. So because of that, PCV will be little bit higher than hematocrit. So hematocrit is a calculated value using the formula HCT equals MCV into RBC count divided by 10. So anything which changes MCV, anything which changes RBC count can change hematocrit. So that is the problem. Right? So the accuracy, hematocrit become unreliable after storage of blood sample. So that means MCV can be stable only for about 8 hours at room temperature. Afterwards, MCV will drop. So if the MCV drops, then hematocrit will drop. Hyperglycemia causes spuriously high hematocrit values. If your patient is a diabetic and having uncontrolled blood sugar, then the hematocrit, the MCV will go up, which will change the hematocrit. And if red cell agglutination is there, it can change the hematocrit value. Now, as you can see in this picture, you can see a lot of red cell agglutinations. So in the analyzer, these cells will be, the agglutinated clump will be measured as a single RBC. So the RBC count will be changed and the NCV will be changed because they'll be taking this as a single RBC. So it can change the hematocrit. So, and the other thing is, if you have done like put a lot of anticoagulants, again it can decrease hematocrit due to erythrocyte shrinking. Analytical variability is also there with different machines. You will see different hematocrits. It's like 2 to 5 times more than the hemoglobin, the variability. So because of all these things, there can be some problem with the hematocrit, accuracy of hematocrit. And if you are doing PCV, again you have to be very careful. You have to allow adequate time to stop the spin. If you stop it halfway through, you can get erroneous values. But anyway, if you want to do PCV, that is only for it will take only few minutes. And if you have any doubt, you can repeat it. You don't have to take the blood sample to the lab. No need of labeling or anything. So I think because of that, PCV will be better than hematocrit. So the clinical red flags of bleeding: persistent tachycardia, especially if it's not settling after fluid resuscitation. When you give fluids, if the tachycardia is not settling, you have to consider bleeding. Especially in adults. Adults, the tachycardia will be a late feature, not an early feature like in pediatrics. And a low systolic blood pressure. Usually what happens during the leaking, initially the systolic blood pressure will remain same, diastolic blood pressure will go up. Because of that, pulse pressure will become narrow, and then later on, after several hours, only the systolic blood pressure will start to drop. But if you have a patient whose systolic blood pressure is low, especially with normal or high pulse pressure, always consider bleeding. And the other thing is, if patient is complaining of dizziness, as we saw during the last couple of cases, dizziness is always you have to consider bleeding or shock. Medications, if patient has taken NSAIDs, antiplatelets, anticoagulants, again these patients are prone to bleed, so you have to consider that. So as we discussed earlier, unstable patient with normal or low PCV, usually patient is bleeding, patient needs blood transfusion. And when you do the scan, if there's no leaking but patient is in shock, or minimum leaking, patient is in shock, we have to consider bleeding. Because if the patient is in shock due to leaking, you will see a lot of fluid in the ultrasound scan. If there's no fluid or minimal fluid, always consider bleeding. And as we discussed earlier, PCV drop of more than 10 points or below baseline after dextran bolus. And don't forget about menstruation. Even though it's normal periods, always give some tranexamic acid and noethistron and stop it, because it can be detrimental if we ignore that. So the take-home messages: pathophysiology of DHF, not only leaking, increased bleeding tendency as well. So 2 things: plasma leakage and abnormal hemostasis. High index of suspicion is needed, so we have to monitor regularly with inward PCV to identify concealed bleeding. Bleeding is often concealed, not obvious, so we have to monitor PCV. That's how we are going to detect bleeding. Do not wait for hemoglobin to drop. It's too late. So if the PCV is dropping, take an action. Early recognition of blood transfusion prevent hypoxic organ damage and save life. So we have to have a very low threshold for blood in dengue hemorrhagic fever. Don't wait till hemoglobin to drop. Bleeding in dengue is a clinical diagnosis that is very important. Act early and act decisively. Thank you.
Thank you very much. We now move on to our final lecture for the day, Hepatic Involvement in Dengue, What Every Clinician Should Know. Delivered by Professor Anuradha Dasanayake, Senior Professor, Department of Pharmacology, Faculty of Medicine, University of California. Professor Dasanayake is widely recognized for his extensive experience in dengue management and is the author of the section on hepatic involvement in dengue in the National Dengue Management Guideline. Over to you, sir.
Good morning, ladies and gentlemen. First, I would like to thank the organizers for inviting me to talk on the hepatic involvement in dengue. So, objective for today is to discuss how to trek towards the zero mortality from dengue fever. I will try to stick into that. So, I think as of yesterday, 48,000 cases, 29 fatal cases. Most striking to me is the very low case fatality rate, thanks to the work by the Thailand team and our team. We have to thank them for that. But these 29 patients, we should not be happy about it, because all 29 are someone's mother, someone's parent, and someone's spouse. So we should try our best to reduce this mortality if possible. So what we can do, maintain the status quo and be happy with the current case fatality rate, which has come down from 20 to 30% 50 years ago to much less than 0.05. Or else, consider and do innovative research on new intervention based on new knowledge acquired on dengue over past 40 years and new knowledge acquired during COVID epidemic and new knowledge in liver transplantation and in immunology. So, why do we still encounter deaths? So many reasons. Obviously, we know about delayed presentation, then delayed identification and suboptimal interventions during shock. Overcrowding is one of the reasons for this, and negligence and poor knowledge about dengue. Then difficult ones, patient-related factors like unhealthy livers, and we can gain a lot by the transplantation experience from transplantation. And then virus-related factors and host immune response factors. So severity of the infection and extreme severity of the cytokine syndrome differs from different virus to different patient, and it's common for even hepatitis A, where only 1% die, so we don't know exactly which patient gets a bad virus infection. So, objectives for the liver involvement to discuss possible mechanisms of liver injury in dengue fever, how to diagnose significant liver involvement early. In the past, most of the cases discussed, physicians have not done the liver function test from the beginning. I strongly advise physicians looking after patients to do the liver function tests early, especially because the liver is involved in the pathogenesis of dengue. It may be not the end result. A liver may be, the disease pathogenesis may be originating in the liver. I will tell you why. Then how to manage acute liver failure aggressively if the patient goes into acute liver failure, and look beyond the new guidelines. So I was in the committee, and where we were careful not to include anything outside evidence. But we are looking at the future. We have to look into various things, so that I am presenting those for the research student, basically, because I know a lot of you are in training posts and that will benefit you a lot. And possible treatment option for the cytokine storm. So we discussed this in a paper very recently from the Ragama group, and I'm going to discuss beyond this paper as well. So mechanisms of liver injury in dengue. Dengue causes liver damage through multiple mechanisms. We all knew this even in 2005. So direct viral effects like the hepatitis A, immunological hyperactivity via the T-cell mediated cytokine storm, and the circulatory failure that leads to decreased hepatic perfusion. And we have been, we knew about it for the past 20-30 years, right? So something that I want to tell you today is what's called ischemia reperfusion injury. This is direct knowledge from the transplant. I will discuss it in detail. That's probably the fourth mechanism of severe liver damage in dengue fever. So it's a unique, strange, complex liver disease, and it's an enigma. So puzzle. We really do not know what's happening inside the liver. So it's a fascinating liver disease for the researchers, but it's a deadly liver disease for the patient and the main cause of death. I personally had bad, scary, traumatic experiences with dengue. I hate the disease, so I like to talk it about in detail. So liver injury, I'm going to talk mainly on hemodynamic aspects and the immunological aspect. I'm not going to do a lot on viral aspects. So unless you detect an antiviral, we are not going to do much about the viral insult. So learn about liver damage, you have to learn about the liver blood supply. So liver is mainly supplied by the portal vein. So 75% of the blood comes from the portal vein and 25% from the hepatic artery. Is there a point? Okay, so good. So portal vein supplies 75% of blood volume and 25% of blood volume supplied by the hepatic artery. Then if you take oxygenation, it's 50-50. 50% of the oxygen from the portal vein, 50% of the oxygen from the hepatic artery. So what does it mean? Liver can easily work if you lose blood supply from the single one. So even the hepatic artery is blocked, liver can still function. If the portal vein is fully blocked, still the liver can function. So this principle is absolutely important in sorry. Mehma. Alright, okay. Here. Methapino. Alright, okay. Sorry. So 25% from the hepatic artery, 75% from the hepatic vein. So 50% is oxygen from the hepatic artery. 50% of the oxygen is from portal vein. So you can lose either single one and still function. This principle is absolutely important if you are going to manage a bad patient with dengue. So liver ischemia in dengue, liver shutdown has very unique characteristics. It's different from septic shock or hypotensive shock. So portal venous supply appears to shut down early in dengue fever, leading to portal hypertension. So there will be a portal hypertension just like cirrhosis, and this appears cytokine mediated. Then arterial supply shuts down later in the illness with the onset of systemic shock. So then only liver is going to be totally shut down, like the patients that we saw who died. So, so this is a research from Thailand where they have shown that in severe patients with dengue, liver blood flow has reversed on Doppler ultrasound sonography. So here there is no portal venous supply to the liver. If the patient survives during this period, he was just managing his liver oxygenation from the hepatic artery. So why do they get this reversal of portal vein blood flow in severe dengue? Is probably due to this. So this is a liver sinusoid where the blood flow is from portal vein and hepatic artery towards the central vein. So in health, this area inside the sinusoid is well maintained. So if you have dengue, due to cytokines, this interior endothelial layer, which is full of immune cells, get attacked by the cytokines, and this is swollen to a level like in portal hypertension due to cirrhosis, there will be hardly any blood supply. Because of that, the portal vein blood flow reverses. So what are the implications of this finding? It can be used in the diagnosis. So it can be used in the diagnosis even before the appearance of the gallbladder wall edema. So portal vein diameter, velocity, and cross-sectional area and the congestive index has been shown to be increased in patients with severe dengue even before the onset of gallbladder wall edema and ascites. So this can increase the detection rate quite early in the illness, and sometimes the specificity can be higher than the sensitivity can be higher than even the traditional markers like gallbladder wall edema, ascites, and pleural effusion. So if you take all of them together, it can make a difference. So in the future, people will be, learn about Doppler studies and start doing it. This observation has still not come into guidelines, and we need nice area to start researching. So then what happens to the liver during this stage? Now you have to learn very clearly about acute liver injury and acute liver failure. So close to 90% of patients with dengue develop acute liver injury, right? Only a very minority go to develop dengue-induced acute liver failure. And if you just get acute liver injury, almost all recover. But if you go into dengue-induced acute liver failure, even in the best of centers, 50% die. So your objective is to make sure that they do not go into acute liver failure, and they should stop at acute liver injury. So we have to think of the ways of doing it and how not to let it go into acute liver failure. And I will discuss what we are going to do even if the patient develops acute liver failure. So what are the implications of portal hypertension in leaking? So obviously it can help in the early diagnosis, and later it can be a target for therapy. So we all know that how capillary permeability contributes to leaking, but we do not know what percentage of that leaking is due to portal hypertension. So I think the portal vein pressure, when the pressure goes up, it is going to contribute massively to leaking, other than increasing the capillary permeability. Ultimately, both of them could be mediated by cytokines. So how to detect significant liver ischemia early, whether it's transaminases or lactate? Liver ischemia is the most lethal cause for liver dysfunction in dengue. I think almost all the patients died. The final nail in the coffin is liver failure, right? So if you diagnose liver ischemia early, we should be able to prevent this. So liver ischemia is the most lethal cause for liver dysfunction in dengue. Transaminases are probably not sensitive to detect liver ischemia early because it takes time to appear. So at least 24 to 48 hours. Why? So there will be no blood supply into the liver. So liver damages, but there is blood to send it back to the circulation. When there is no liver blood supply, how can we detect transaminases in blood? No way. So if the liver is not being supplied, it will take time. Only after you dextran and restore the intravascular volume, they will come to the circulation. That's why you see 7,000, 10,000 rise. After you start to detect the shock and start pumping in, then only you will see the rise of the transam. It's a simple logic, right? So what I want to tell you is that lactate is more reliable. So lactate is very easily obtained even in a peripheral unit if there is an ICU. So if you can get the lactate, it will tell you what's going inside the liver. I will tell you why. And that's because lactate is predominantly eliminated by the liver. So AST is important in liver disease due to dengue because usually ALT is more than AST in health and disease. In dengue, AST overtakes ALT after 48 to 72 hours. So if the AST level rises steeply, if it skyrockets compared to ALT, we know that there is cell death inside the liver. Say if it is ALT is 90, AST is 600, you know that there is massive liver cell necrosis. But why AST rises beyond ALT in early disease, still we do not know. It could be either hepatic ischemia from early stages or destruction of massive killing of immunocytes like monocytes by the dengue virus. That is still not exactly known. So lactate, I want to discuss lactate deeply because lactate knowledge is from liver transplantation. I will tell you why. So product of tissue ischemia, obviously, and wherever lactate is produced, it has to be cleared by the liver. So majority of lactate is cleared by the liver. So if there's a rise of lactate in, say, septicemia or limb ischemia, it will be eliminated by the liver. But if lactate is risen due to tissue necrosis and hepatocyte necrosis, it climbs steeply. It skyrockets, like the patients we saw, 2 to 7, 2 to 10. What it means is that there is no liver blood supply, and at the same time, liver is 1.5 kilograms of tissue. So if liver is necrosing, then lactate jumps. So if there's a rapid rise of lactate, you have to think of liver involvement in dengue. So 2 patients I'm going to show you. This is the lactate in a patient with dengue. So say 3 to 12. So with liver ischemia, it skyrockets, and this is on transplantation, absolute reverse, because in transplantation, liver is kept outside the body for 6 hours and then put it back to the recipient. Then lactate is 2.7 because that patient is without the liver for 6 hours. Then if the liver is functioning, lactate gradually drops rapidly. So then that's the best sign of the liver working. So that knowledge is from liver transplantation. So I think liver transplantation is the best model to study ischemic livers, right? and maybe COVID is the best model to study cytokine storm. Okay, so early detection of liver injury, I think all the patients that we saw presented by two speakers, clinical parameters were ignored by the physician. See, unexplained tachycardia, right hypochondrial pain and epigastric pain. Severe epigastric pain in these circumstances is not gastritis. That stretching of the liver capsule due to liver getting edematous due to cell death, and persistent vomiting, restlessness, all features of massive liver cell necrosis, and then the lactate levels and the novel markers can be Doppler studies and so on. So lessons from transplantation may be relevant in dengue liver damage as well. So liver regeneration capacity. So liver is capable of regenerating massively. The only organ in the body which can regenerate massively. So in live donor transplantation, you take out 70% of the donor liver and it's transplanted to a patient. So you are left with 30% of your liver, and within 3 weeks, that liver grows back to your normal size. Then the transplanted part of 70% grows back to that patient's normal size. So it's a miracle, right? So what I have to tell you is that you have to look after the liver and try your best to keep the patient alive, so that you give time for the liver to regenerate. So that's what. Then high-risk liver. The concept of high-risk liver. So I will tell you exactly which livers are high-risk. Then ischemia reperfusion injury. I will tell you what that also in the next slides. And use of lactate as a marker. So 4 points to learn from liver transplantation, right? So these are what are called high-risk livers, not taken for transplantation. Fatty livers, diabetics due to fatty liver and other issues, hypertension, obese, age. So all those livers are considered high risk for donation. So we don't take livers for donation from these people, right? So if you have a patient with these risk factors, like in COVID, right, you have to look after their livers more carefully, because these livers can go into liver failure with even little bit of ischemia. I will show why that happens, right? So unfortunately in Sri Lanka, I think close to 50% of middle-aged and adult people have fatty liver. So that's deadly dangerous. That may be why you see more adults dying now, more adults early to children. So that may be one of the reasons why more adults die. Now see the upper sinusoid that I saw you earlier, very clear sinusoidal lumen. See this one. This is a lumen of a patient with fatty liver. So absolutely little space for sinusoid to work with. So even with very little inflammation in the endothelial cell layer, it can be blocked. So this liver very unlikely to survive with a major ischemic episode. This is ischemia reperfusion injury cycle. So what happens with ischemia reperfusion? It's the injury that occurs when the liver is this common for all transplantations and all ischemia reperfusion injuries. There will be ischemia if there is blood loss, right? So then if you reperfuse, that liver is not going to start working immediately. So you can lose blood supply for less than 30 minutes without getting the ischemia reperfusion injury. If that blood supply is lost for more than 30 minutes, it starts this major cycle of ischemia reperfusion injury, and that has to be managed. So in transplantation, the anesthetist, waits for this, right, ischemia reperfusion injury. Then the moment the liver is perfused, this liver is outside the body for more than 6 hours. So transplanting, you perfuse, within hours you get vasodilatation, cardiac arrest. That's because the entire liver will have substances produced during, period where there was no perfusion. So all the lactates and all the ammonias and toxins that are produced during this period where there was no perfusion gets back into the circulation, and body reacts, and there'll be vasodilatation, cardiac arrest. So what they do is to, they should get ready for that and start with inotropes and various methods, and it's up to them to make sure that patient is alive during reperfusion syndrome. So what I notice in dengue is that we have not addressed this issue. So if a patient has been in shock, like the another's patient, I think we have to manage that post-perfusion period very vigorously, right? I think we have to read about it, and we should know what to do in a patient who is being reperfused after a period of ischemia. That if that period is maybe more than 2-3 hours, that liver will not survive. So that's why sometimes we find it very difficult to revive these patients following a period of shock. You can't do anything for that. Only thing is to make sure that they don't go into shock and kept in shock for longer period of time. So then I will come back to acute liver failure. So now we have failed all this, and the patient has gone into acute liver failure. So how are we going to diagnose acute liver failure? This is the definition. INR of more than 1.5 and any grade of hepatic encephalopathy. So it's usually acute liver failure which is going into multi-organ failure. So whether this patients with dengue gets simultaneous multi-organ failure, I don't know, right? So from a liver point of view and a theoretical point of view, if you see, learn the pathophysiology of dengue, it's more like liver failure which is going into multi-organ failure very quickly. So you have liver failure within 24 hours, the patient is going to get multi-organ failure. So that's common for all acute liver failures, and this is relevant for liver transplantation. And there are few liver transplantation attempted in dengue acute liver failure, and there have been successful transplants as well, I think 4 or 5 in the entire world. So what they talk is that you have to catch them while having the acute liver failure rather than the multi-organ failure. If the patient has gone into multi-organ failure, very unlikely that the patient is going to survive. So if you get acute liver failure within hours, the patient is going to get manifestations of as a result of acute liver failure, you are going to get multi-organ failure. So did you ever think why a patient, this young girl dying of dengue, ventilated, right? So why this patient is like that? We've all seen this patient, very toxic, unconscious. Why is that? So I will tell you why. So there has been the remnants of the cytokine storm. So the liver is the one who usually takes out cytokine. So remnants of the cytokine storm is there. So toxic and waste products from the necrotic hepatocytes. So liver is 1.5 kilos of tissues, right? So here, by the way, liver has 1.5 kilos of tissue. Of that, 1/3 is immune cells. Then 1 kilo of hepatocytes and 500 grams of immune cells like Cooper cells. So liver is the main immune organ of the liver. That's why the liver is attacked by the cytokine storm. So we have 1.5 kilos of dead tissue. So this patient is harboring 1.5 kilos of dead tissue. So usually those toxins are eliminated by the liver. Here the liver is not working, so this girl cannot eliminate that toxic substances. Then the body reacts to this. So all the toxins produced by the systemic inflammatory response syndrome. Imagine the amount of toxins they have. And finally, inability to get these toxins out of the body, which is done by the liver usually. And all these toxins are now accumulating and the patient has developed cerebral edema. So that's why this patient is like that. So that's why all these new interventions in liver failure sound sense. So try and eliminate these products till the liver starts functioning. That will take 2-3 weeks. So what you have to do is to do PLEX, maybe plasma exchange, and CRRT. I will come to details about this. Do PLEX, plasma exchange, and maybe CRRT in certain patients, so that you remove all these toxins starting early. Should not let these patients go into this stage, cerebral edema stage. Then it's going to be difficult. So start removing them early. As soon as you diagnose acute liver failure, start removing them early. So in Sri Lanka, there are units that are doing these things. It will take time for them to be, experienced in this. When this, when you gain the experience and the expertise, finally all of them will be successful. So give them time, they will learn how to do it. And I think people are doing a good job now in certain units. So for treatment, N-acetylcysteine was introduced in 2009. Dr. Anand wanted me to tell you that it's not just doing N-acetylcysteine. I don't think it's powerful enough to treat these patients, right? So main thing that you have to do is make sure that liver is perfused. Make sure that intravascular volume is maintained at all costs. Not just start in acetylcysteine and wait, right? It will not work, right? It's something he has observed over the years. People think that by starting in acetylcysteine, you are going to safeguard the liver. No, that will not happen. So one of the earlier treatment options in 2009. And after that, there are newer treatment options like PLEX, CRRT, and CRRT combined with PLEX, right? So the last major paper I read was PLEX combined with CRRT 2023 in Vietnam, 34 children, and most of them were saved. Most of them were saved, right? So I think we have to go towards that way. So I think the most important lesson is to detect liver functions early. Start doing liver functions early. And if you suspect the patient is deteriorating, please do a lactate. That will tell you what's happening. It's not the AST/ALT, right? And if you don't have a lactate level, I think you send the patient to a place where there is lactate level available, right? So think of clinical deterioration and clinical parameters like tachycardia. Unexplained tachycardia in the absence of fever is a very good indicator of something wrong happening inside the body. So then I will come to the novel treatments, right? So I told you about dengue-induced acute liver failure. For the future, what are the, if you think of outside guidelines, right? Can you prevent dengue-induced hepatitis worsening into acute liver failure? And people are thinking of that, right? So why do these people get very severe cytokine syndrome? Only some get, only some don't get. Why? And can we do something for this cytokine syndrome, right? So I told you that I'm not going to tell you about antivirals because I don't know, right? There were, some people are talking about antivirals in dengue, but I don't know when it's going to come. I don't know when the vaccine is going to be available. I don't know when the Wolbachia start functioning. I don't know, right? So I think at least for the next 5 years, you have to, start to, we have to be managing patients, right? So of that, antivirals, I don't think there'll be an antiviral for the next 5 years. So have to, tolerate that, right? So then, but what we can do is to make sure that liver is not going to get hypoxic due to hemodynamic stability. That we can do, right? Then immunological challenges in the future, what we can think of the immunological challenges. So cytokine syndrome is deadly. So cytokine syndrome came to the fore because of the COVID epidemic, right? So we didn't know about cytokine syndrome a lot, say, so when we started treating dengue patients 25, 30 years ago, right? So now we know that why this patient is toxic on day 4, day 5, day 6. Very high fever, very moribund, ill-looking, diarrhea, right? So that's probably cytokine syndrome. So why it kills the patient? Again, mainly through liver involvement, and it originates, cytokines are originating from the immune cell, and most of the our immune cells are inside the liver. So it starts, when the cytokine levels go up, some of them, initiate leaking, and some of them start pushing them towards the leaking cells through portal hypertension. And all the initial manifestations of leaking appear in the portal circulation. It's not in the brain, right? So it's all the initial leaking consequences are in the portal circulation. So gallbladder wall edema is portal hypertension of the gallbladder. Blood pressure drop is immune mediated, but in addition you get a splenomegaly, right? So then that's due to portal hypertension. Upper GI bleed is a portal hypertension manifested. Leaking and right-sided pleural effusion is a manifestation of exactly what you get in ascites, right? So there are a lot of portal hypertension contributing to leaking, right? So what is causing portal hypertension? It's all again cytokine. So what initiate leaking? Again cytokine. So there's a lot of interest in cytokines now, right? So people are questioning whether is severe dengue a cytokine syndrome, right? So that's for the future, right? So if you want zero deaths, right, I think we should move towards understanding the illness better, learning the pathophysiology better, right, and act along that line. So what can we do for the cytokine syndrome? These are pro-inflammatory cytokines, right, like IL-6 and, tumor necrosis factor alpha and IL-10. And we should, if you can check the levels of IL-6, say day 4, 5, day 6, then we can do something, right? But if you can't do those levels, then at least we should have a surrogate marker. So what I read, these are surrogate markers, and CRP and ferritin. They may not be perfect, but they can do something, okay? So IL-6 is responsible for vascular permeability, coagulopathy, fever, and these are more common in secondary dengue, not in primary dengue. So others include TNF-alpha and IL-10. So can IL-6 predict severity? Yes, apparently in studies it has shown to be useful in predicting. Only thing is who can do IL-6? I don't know, right? So then ferritin, right? So it has two use. You know that ferritin is very strange, right? Ferritin, we have seen people with 100,000 ferritin survive even without any intervention, right? Just because ferritin is 10,000, I don't think we have to act. You have to take it with other parameters like very high fever, very high liver enzymes, right? And, pancytopenia or bicytopenia, right? Just one reading of ferritin is not a good marker. But why do you get this skyrocketing ferritin in liver? So ferritin skyrockets in dengue, and of the infections, I think it's only dengue. Then Still's disease, some of the rheumatological disorders, right? So why, from where does this ferritin come? One is from the liver. So if there is a significant liver damage, ferritin jumps. And if there is immune activation, then ferritin jumps. I think in dengue, it jumps due to two reasons. There is significant liver damage, there is significant immune activation. So people have tried to, see whether this can help in the diagnosis, right? So there are papers to suggest that, this our paper from Ragama, that, day 3 and day 4 ferritin can predict late leading. So not perfect. We don't have perfect parameters or indicators, but if you take in with combination with other indicators, it might help. So we have still not included any of these into guidelines. These are for the future, right? Okay. So interventions in cytokines, this from COVID experience, corticosteroids, tocilizumab, and therapeutic plasma exchange with or without cytosol. So these are things that were tried. I will take one by one. So why immunosuppression does not have benefits in dengue but had benefits in COVID? My guess is that the studies were not timed well, right? So one reason is that we got COVID in US, UK and France, right? So I think best is to import dengue to US, UK and France and Spain. Fortunately, I think dengue is already in France due to climate change. Dengue has gone into US. So if they go into US and France, they will detect something, because it's a poor third world country and pharma companies are not interested at all, right? So it's a poor man's illness, right? So I think there are deficiencies in testing all these, right? So two widely cited studies, one on methylprednisolone, is tested in patients in shock. Obviously, it will not work. So this other study where they used 15 milligrams of prednisolone for 3 days, compared it with 90 milligrams, that's 0.5 milligrams, and then 2 milligrams per kilogram for 3 days in all patients, blanket cover, right? Again, I don't think it's used because we need something only in these 28 patients. We do not need anything, and the present guidelines are good enough for 46,972 patients. So we need something in a minority, right? So you should check something on them only. So you have to predict them beforehand and try something on them, right? So there are a lot of arguments on whether why corticosteroids work, why they don't work. See the number of papers on that, right? See, this is how Senaka Rajapaksa. So, don't know. So then what about tocilizumab? So why it works? IL-6 receptor antagonist. So theoretically it should work, right? So people have tried in case reports, right? Working. Probably working, right? So plasma exchange theoretically should work here. What you have to do is remove cytokines, right? So theoretically should work. Used in COVID, widely used in acute liver failure. So I'm talking about the cytokine stock. Before going into acute liver failure, as I told you, if we prevent them going into acute liver failure, we are going to save 50%. So if you send them into acute liver failure, then you lose the chance of saving 50% of the patient, right? So this is plasma exchange is approved by CRO guidelines for dengue and acute liver failure. So what does it do? So it removes cytokine, and because you are taking something out, it removes ammonia and bilirubin as well, right? So that's the beauty of plasma exchange over, say, NACO, other interventions in acute liver failure, right? So the only thing is plasma exchange is expensive, you know that. If you do it outside, it will cost 1 million, right? So it's not easy to do plasma exchange outside the hospital setup. So here again, we have to, there are so many other patients who need plasma exchange, like neurology patients, hematology patient, renal patient, right? So divide the scarce resource among them, so it's not easy to arrange plasma exchange all the time, right? Okay. So these are the use of case reports on use of plasma exchange with cytosol from our team in Colombo, and this is a use of in cytosol with plasma exchange in multi-organ dysfunction, right? Okay. So then coming to HLH, right? Okay. So now it is gaining a lot of interest, HLH, right? So we are managing HLH on 2004 guideline, which was formulated to treat hematological and rheumatological, right? So we need someone to, I think the college and the dengue unit, they have started collecting data on LH to LH2 develop guidelines for dengue, right? Okay. So to summarize, ladies and gentlemen, so few new things to tell you. Evidence to believe that portal hypertension may be facilitating fluid leak. Doesn't look like only the permeability of the endothelial cell wall, right? So getting an ischemic liver back to function needs a lot of skill and effort. So we have to now keep in mind and learn about reperfusion syndrome, and and learn how to manage it. Then it will be easy for you to manage patients following patients who are in shock better after reperfusion, right? So because of the dual blood supply, liver may escape serious injury if the blood pressure is maintained. So portal vein, the venous ischemia appears to be cytokine mediated. Arterial ischemia is likely to be hypotension mediated. So if you maintain the intravascular volume, you should be able to save this patient, right? Until we find a solution for the cytokine syndrome. Healthy livers has the potential to regenerate even after massive necrosis. So don't give up. Don't give up. Do plaques, do CRRT, and allow the liver to regrow. And if you can manage them for 2-3 weeks, potential to regenerate. And unless the entire liver structure is destroyed, if the structure is maintained, only the hepatocytes are dead, there's a chance of regeneration. So then for the future, early interventions during cytokine syndrome before the onset liver failure could improve the mortality further, and that's for the future and research for the research student. Thank you very much for the kind attention.
Thank you very much, sir, for that comprehensive and enlightening presentation. We now come to our expert panel discussion. Joining us are 3 speakers whom we have already had the pleasure of hearing this morning: Dr. Ananda Vijay Vikrama, Dr. Damayanti Idampitiya, Professor Anuradha Dasanayaka, together with 2 other distinguished experts, Dr. Srilal De Silva, a retired consultant pediatrician, currently serving as the chairperson of the National Dengue Death Review Committee, and Dr. Jagat Amrasekara, consultant community physician attached to the National Dengue Control Unit and a member of the National Dengue Management Guideline Committee. Moderating today's discussion is Dr. Dumita Govindapala, Senior Lecturer at the Faculty of Medical Sciences, University of Sri Jayawardhanapura, and the convener of National Dengue Guideline Committee. I now invite Dr. Dumita Govindapala to commence the panel discussion.
Good afternoon, everyone. First, I would like to express my sincere appreciation to all those who have joined us today, both on site and online. from 17 centers across the country. Actually, your participation is a testament to the enthusiasm, dedication, and the commitment of healthcare professionals in this country to improve the dengue management and patient outcomes in this very challenging moment. I think so far we had a very fruitful discussion with 3 excellent presentations. And as we move on to the panel discussion today, I'm going to focus on 3 main areas. First, about the current situation of dengue in the country, where I would be asking some to update us. Dr. Tilanka Bandara from National Dengue Control Unit is joining us. And then we will focus on the important updates and emerging areas in the revised National Dengue Guideline, where all 3 speakers who have contributed to the guideline will be updating us on this area. And then we have, thirdly, I'm going to discuss a bit about lessons learned from the recent dengue death reviews. Dr. Srila De Silva, the chairperson of the Dengue Death Review Committee, will be joining us soon for this part of discussion. So, we have a very expert panel today, so I would like to invite all of you to actively engage with this discussion. Those who are on site can directly ask your questions, direct your questions to the expert panel. And those who are joining us online, please type your questions and SMS it to the provided mobile number. We will take up your questions. So let me first start with Dr. Tilanka Bandara. We have seen a rapid rise in the dengue cases in recent weeks, with over 1,000 patients being reported in a single day. This raised the concern about a major outbreak of dengue in the country. So, Dr. Bandara, how does the current situation compare with year 2017, where we had a very bad outbreak? And should we be concerned about similar scenario? And what are your predictions for the coming months?
Thank you, Madam. Currently, as per the 23rd of June 2026, we have 48,287 reported dengue patients in the country, with the month of June so far having about 14,500 cases. And we have 14 at-risk districts that we have recognized as Colombo, Gampaha, Matara, Kalutara, Ratnapura, Galle, Kandy, CMC, Hambantota, Kegol, Kurunegala, Batticaloa, Putlam and Kalmune. So those are the at-risk districts that we are seeing lots of patients coming in these days. When comparing to the 2017 outbreak, during the 23rd, 24th weeks, we have, when we compare the epidemic curve, the 2025 curve has just gone above the 2017 curve within the past 2 weeks. However, we are also seeing a drop in the number of cases in some areas. So, to your next question, considering what is going to happen in the future in the next few weeks, since we are currently in an outbreak situation in several districts, we might see the number of patients that we are seeing in admissions for a few more weeks. And with the current preventive and control measures that are in place, and with the support of the Ministry of Health, the Ministry of Local Government and our defense forces and all of that, we are expecting the levels to come down.
Okay, thank you, Dr. Bandara. So as the case numbers rise, the hospitals are coming under increased pressure. So appropriate admission decisions are therefore critical for clinicians. This is very important. So I would like to ask Dr. Vijay Vikrama, what are the key factors clinicians should consider when deciding whether a patient with suspected dengue needs admission or whether that patient can be managed as an outpatient, particularly in this current outbreak setting?
I think in this regard, the Minister of Health has issued a circular which gives many suggested methods of addressing the present situation. I think those should be tailored according to the institution and the caseload, of course. Some suggestions are like having a fever corner in the OPD so that the patients who are coming to the outpatient department are screened, and then to decide who are to be admitted and who are not to be admitted and followed up, so that we can have just based on risk-based admission, and also not to miss cases which can patients who can develop complications, so that they can be admitted, and others can be managed as ambulatory patients with the proper advices and follow-up. And for that, we will need to have full blood counts available within a very short period. So these things have to be coordinated within the hospital, and sometimes we might need additional support. Now in 2017, there were a lot of activities happen, and we can get that experience in this situation also, because I think still we haven't reached the peak. Generally, the numbers peak in July, month of July in general, when we take the general incidence. So it is possible that we will get more patients during the coming 2-3 weeks. Hopefully it will go down at least after that. So the measures we have to take as based on the caseload and the availability of facilities at the institutions, but having a full blood count done within a short period is a must for OPD patients, and then monitoring them, and then once admitted, monitoring them. I think a lot of wards in many hospitals are overcrowded now already with dengue patient, but already you have other medical patients also in this ward. So this has become a real difficult situation to monitor these patients, to detect who are going to get bad. And then doing regular blood pressure monitoring, the regular PCV monitoring, those have become a big problem. But if possible, what can be done in now to have a separate area in the hospital to have these patients, if it can be done. This will need a lot of administrative input. However, if it is done, we'll be managing the same number of patients with the same number of staff within the same space. So it's just segregating these patients to a different area. So if that can be done, things will be, I believe things can be done in a much easier way. But then the staff working in that area will be can do things much more accurately and with less stress, and also the chances of missing other patients, like a patient with ischemic heart disease or patient with high blood sugar, those problems are also there. So if these patients can be segregated, then things can be easier. But of course, for that, you will need a lot of administrative support. And it's something, initially, there can be a lot of resistance from staff. Even though when you look at that, it is the same number of patients you are managing with the same staff in the same space. And then having sort of small leaflets for the patients who are being followed up, prepared, that there are already ready-made leaflets which can be used, printed and photocopied and used at outpatient departments to give patients when they are coming for the follow-up. So them to mark their full blood counts, that then maybe the urine output or the intake also, and also the advices. So such things will be useful in managing this number of patients. And if the numbers haven't gone up still in some hospitals, you have to anticipate a rise within the next 3 weeks and get ready.
Okay, thank you, sir. Since you have highlighted the importance of having a dedicated area for managing this increased number of patients in outpatient departments, especially in other words, to have a fever corner. So I think the ministry has issued a circular yesterday of having fever corners in each and every hospital for these patients. So I think in NIID, Dr. Idampitia has an extensive experience in managing a large number of dengue patients as outpatients. So I have two questions for you. One is, what are the, can you briefly tell us the outpatient management of a patient with suspected dengue? And the second question is, in your experience, how to establish a fever corner in a hospital, because we have a lot of physicians joining us today.
Okay. So we have a fever corner which was established earlier also in I think 2017 also we had one, but later on it was non-functional and we have established a new one. So in our fever corner, what we do, patients can directly come to the fever corner if they are suspecting that they are having dengue, or doctors can refer from the OPD or from the outside like GPs and all. And we do the count then and there. We have a fast track. We can send the count to the laboratory and we'll be getting the report within half an hour. And we do the NS1 antigen also then and there. And so depending on the count, and we have a nurse, it's a nurse-led management system. If they need us, they'll be calling us. So they'll be doing the monitoring the blood counts. Then they'll be taking the history, especially to look at whether the patient is having any warning signs or not. So those are the two things they are looking for. And in addition, they check the blood pressure, check the pulse rate, and then they instruct about the intake and urine output. So according to the patient's weight, they tell how much fluids to be taken and what is the expected urine output and how to measure that. And so they'll be, now, if the patient is okay, no problems, and if the patient's counts are high, then they'll be sending the patient home and asking the patient to come on the next day. So they'll be monitoring like that. And if patient develop any, if any warning signs, so they get the advice from the doctors and admit the patient. Or if platelet drops below 130, they admit the patient. So that's what they do in our fever corner. So a lot of patients are registered there. So when they have a separate leaflets and they have a separate chart to maintain daily the patient's counts as well as the vitals. So when the patient is getting admitted, they'll be sending the patient with that chart. So we know what was the day one platelet count and what was the blood pressure and all. So the next day, so it's like the regular vitals as well as the counts are there. So that's what we do. I think it's quite easy for us to manage it like that because we don't have to admit each and every patient. So if they are finding it difficult, we'll be going there and we'll check the patient, and sometimes we do a scan as well then and there, and then we decide whether to admit or whether to send the patient home.
Okay, thank you. I think it's time for all of us to consider setting up dedicated areas in our outpatient departments to manage this large number of patients, because otherwise our hospitals will soon get overcrowded. So we have, it's a key addition in the new guideline, the outpatient management of suspected or confirmed dengue patients. So you have the guideline available online. So please refer to the guideline if you need more information. So Dr. Idampitia mentioned about NS1 antigen. So this question is again to Dr. Vijay Vikram and Dr. Idampitia both. Now it's been widely used in the outpatient setting, and even the patients know dengue test. So they come and ask, doctor, can we do the dengue test to see whether I have got dengue? And if it is negative, sometimes they are very happy, but it's not for us. We can't exclude dengue. So my question is, what are the limitations that clinicians should be aware of when they are performing the NS1 antigen test, and how should they interpret it, and what is the perfect time for doing the NS1 antigen test if you are suspecting dengue in a patient coming with fever?
Yeah, I think this is a very important question. I think my first answer would be tell the patient not to be happy, because still it can be dengue. I think that is what one has to tell the patient if the test is negative. Of course, if it is, the sensitivity varies significantly depending on whether it's a primary dengue or secondary dengue, and also at what point of time you do the test. Generally, the sensitivity is highest if it is done within first 72 hours, so preferably at the end of 24, on the sort of over the second day or so, or even the first day. But many patients come generally on the second day. In the primary dengue, it is said the sensitivity can be around 90% or between 80 to 90%. However, in secondary dengue, it can go down to about 50-60%. So about more than 1/3 or half of patients with secondary dengue antigen test can be negative, even if it is done within first 3 days. So this is something which we have to tell the patient, and also sometimes the general practitioners do this and then they say it is negative and they also relax and the patients also relax, and then they might not come for the follow-up. So that is the biggest problem we have. We make decisions based on the full blood count and once admitted with the PCV and other vitals. And so doing the test is okay provided it is available, and if you don't spend, or the patient doesn't spend money, but we have to be cautious about the result.
Anything to add, Dr. Vijay?
As Dr. Vijay Vikram mentioned, it's become positive mainly in primary dengue rather than secondary dengue. So if the patient is having secondary dengue, they are more likely to get complicated than the primary dengue patients. So we have to be very careful if the test is negative. Still, if the patient is, if you are suspecting dengue, we have to manage it as dengue rather than say negative and no need to do anything, because patient can get back with time. So the best thing is to follow up with full blood counts rather than NS1. So if we have the NS1 positive, so that we know that it's dengue, but NS1 negative doesn't mean that patient is not having dengue.
Yes, I think we have to clearly convey this message to our patients, especially in the outpatient setting within first few days of the febrile phase. When they come with a negative dengue test, they may be very happy that they don't have dengue, but we have to clearly tell them that you can't exclude dengue just because the test is negative. So my next question is to Professor Dasanayake. So fever and body aches can be disabling in the febrile phase, and the patients expect us to give something to relieve their discomfort, pain, and fever. But our options are limited. We only have paracetamol, which is considered to be safe in the febrile phase for these dengue patients. So my question is, what is the considered safe dose and dosing interval of paracetamol in suspected dengue patients? Because you talked about unhealthy livers, so it is not the same for each and every patient.
Kuntima, thank you. I think if they have not gone into liver failure, can use the normal doses. 1 gram 6 hours in an adult. Other options include giving paracetamol IV. I think IV paracetamol has a bit better effect on pain, but it can be given only in a hospital. Tramadol can be given for pain, and sometimes a mild sedative to sleep. But if the patient has deranged liver functions, very much deranged liver functions, and approaching liver failure, then you have to go for the half dose, maybe 1 gram BD. And if they have reached liver failure, best to avoid paracetamol.
So if the patient is having underlying liver disease like diagnosed MASLD or chronic liver cell disease,
MASLD is fine, but if they have cirrhosis, better to start with, unless if he is not in failure and again cirrhosis per se, you can go for the half dose, 1 gram BD. It is recommended to give paracetamol half dose even in patients with established liver disease, that's compensated cirrhosis. They are decompensated, best is to avoid. Then you can go for tramadol, but tramadol has its own complications like sedation, maybe constipation, can precipitate encephalopathy. If you need to give something, I think you would go for tramadol in these patients.
Thank you. So anything else to add about other options to manage pain and fever?
So I don't think any other option, but tepisponging and those things, I don't know how much it's, for just for fever. So I don't know, but anyway, patient feels better. So we are practicing it.
I think it is a very important point in the outpatient management. We should not be using other analgesics, especially NSAIDs and steroids, in the febrile phase when managing these patients. So with regards to outpatient management, the other important question is we do come across patients with a lot of comorbidities like ischemic heart disease, diabetes, hypertension, and CKD. Most of these patients are either on antiplatelets or antihypertensives, diuretics. So my question is again to the two physicians. So when do you consider stopping this medication? So they might come to you on day 3, day 4. They must be on ARBs, ACE inhibitors, and diuretics like loop diuretics or spironolactone, and they must be on clopidogrel aspirin. So it's very difficult decision. So should you be stopping antihypertensives, antiplatelets immediately, or what would your recommendation for the audience?
Basically, dengue is a bleeding disorder. Now, we give antiplatelets and anticoagulants in patients who are likely to have clot formation. Now, here the possibility of formation of clots are very minimal. So, therefore, and on the other hand, the risk of bleeding is high with the progression of the disease. So, therefore, it is important that we stop all antiplatelets and anticoagulants in these patients. In fact, my first experience on this first immediate problem we had was, I remember maybe about 10 years ago, I had a patient who had a stenting done 3 weeks prior to the getting dengue. And he was on dual antiplatelets. So I was not sure whether we can stop. We have been stopping, but when the stenting was done just 3 weeks ago, I was not sure whether it can be done. So I called a backmate of mine, a cardiologist, and got his opinion on advice on this. So he immediately said, you stop that. So I asked, will there not be a problem? He said, no. Then he gave the reasons. Then he said the action of aspirin will gradually wean off and it will go on for next 3 days. So therefore, there's no immediate problem in clotting, and by that time, the platelet would go down further. They said, anyway, there's no question of having a clot. So we stop all that. On the other hand, antihypertensives and diuretics, if they have been on those for long term, we continue that. It is very important to continue antihypertensives unless they become hypotensive. That is because if the patient's blood pressure, now we have seen some occasions where antihypertensives had been stopped and the blood pressure were apparently normal. Normal in the sense there's a blood pressure 120/80 or 110/70, that range. But then for a patient who is having hypertension without antihypertensives, having a blood pressure of 110/70 is not normal. So that is the problem. So the patient eventually went into shock and died. So the patients are having normal blood pressure with antihypertensives. So we know what their figures are with antihypertensives. So it's important to continue that. Diuretics, we don't have any evidence, but the rationale we use is their body systems have been used to this long-term diuretics. So we continue those. That's the rationale we use.
Anything to add, Dr. Dampitia?
We also stop antiplatelets and anticoagulants. In anticoagulants, sometimes the problem occurs if the patient is on like dual valve replacement, and also the cardiologist a bit reluctant to stop those things. So if the patient is on warfarin. So if the patient is on warfarin for phenol, we just stop these things. But if the patient is having any very like dual valve replacement or mechanical valves or something like that, what we do is we initially convert it to enoxaparin or heparin, and then once the platelet count drop below 50,000, we completely stop it. And when it comes back to 50,000, above 50,000, we restart the heparin. And then once the platelet counts are normal, we go back to warfarin. That's what we do, but there are no evidence to say what is the best management option.
Yeah, I think
If you may add, there had been occasions where people have come across myocardial infarctions with dengue. I would say that would be extremely rare occurrence. So we make these guidelines not for extremely rare cases. If you get a clot with the platelet count of 50,000 or 40,000, that would be a extremely uncommon thing, and probably not the clot, it may be the rupture of the plaque causing the obstruction. So maybe that sort of rare possibilities are there, but those rare cases are not a reason to continue not to give antiplatelets or anticoagulants.
At the same time, we have to tell the patient once the disease is over, we have to restart the day, because platelet counts can go up very rapidly, and then they can present with a myocardial infarction later if we don't start antiplatelets.
Yeah, I think it's a very valid point, because once you stop these medications when you are discharging the patient, you should have a plan for the patient when to restart these medications. So again, my question is to Professor Dasanaik. I think you have mentioned this during your presentation as well briefly. So liver plays a very important role in dengue, because the disease, actually the virus is a hepatotrophic virus. So monitoring liver functions is very important in a dengue patient. So we have added a new chapter to the revised guideline on hepatic involvement in dengue, authored by Sir. So how would you advise the audience on monitoring liver functions from the febrile phase onwards in a patient suspected or confirmed with dengue?
Yes, thank you. As I told you, liver plays a major role in pathogenesis. So it's, as I told you, it's the dominant immune organ in the body, and liver contains 1/3 of the liver mass is immune cells. So from the beginning, there will be changes in the liver functions, and by third day, AST overrides ALT. Why that happens, we don't know. So we included in the guideline to monitor, especially in patients who are ill, monitor liver functions twice a day from third day onwards. And also, if you suspect major liver damage, to do lactate. So that we included in the guideline, and both the patients presented by Dr. Vijay Vikrama, we would have detected the liver injury quite early, and in one patient till the 6th day, lefties are not done. So I think it's a good move to do liver function tests as a baseline on admission, and checking it twice a day if the patient is very ill looking. So this clinical impression plays a major role. So I don't think one can have major liver involvement, while reading social media. So usually what they do is to keep the phone aside, and and then they look very ill, and then on the 5th, 6th day they go back on social media. So then we know that the patient is improving. So if the patient is very ill looking and platelet counts dropping, PCV rising, I think we have to do liver functions twice a day. And if the patient, you suspect liver involvement, best is to do lactate. I can't overemphasize that fact. So important. So I think the first two patients, one survived and one died. I think the farmer survived because he was working and his liver was normal. As he said, if he was a diabetic, he wouldn't have survived that assault. But in his case, I think LFTs and lactate was not done until the 6-7 day. So then, when you checked it for the first time, it was 700 and 1,400 something. So please do LFTs, and if you suspect, even suspect severe dengue, please do AST/ALT twice a day. And if you suspect deterioration, always do lactate level. Best is to do the lactate level.
Thank you, sir. Yes.
If I may add, I think it's a good practice, as Anna suggested, to do the SGOT patients on admission. In all patients who are admitted to do SGLT. And then if it is depending on the level, and now some patients it may be in 800-900, which is not usual. Usually those will be about 200-300, isn't it? That on day 3 or so. But if it's occasionally we see patients who have very high levels, which needs closely follow up. But in others, then depending on the value and their clinical symptoms, we can decide when to repeat. And I think it is important to do a venous blood gas in any patient who goes into shock or presents with shock. So we can have a fairly good assessment, as Professor Anurad was pointing out, is in his talk, about the level of degree of damage which has occurred, or in other words, for how long the patient had been in shock. So we can get a fairly good idea, and also we see the response to fluid. With repeat venous blood gas, we see the response to fluid. So once resuscitated, we can do it again and see the response. So in all shock patients, I think it is important to do venous blood gas to assess lactate.
I think it's a very important message to the audience if you are seeing patients in your outpatient clinics. So make sure, in addition to the full blood count and NS1 antigen or the CRP, to do at least ALT and AST when they first present to you. And if the AST and ALT are high, be little vigilant. These are the patients who can get complicated later. So that's the message that we want to give to the audience. And coming back to the surveillance data, because in an outbreak like this, surveillance data is very important, especially for the public health authorities to monitor the disease trend and to implement the control measures. So my question is to you, Dr. Bandar, again. Could you briefly explain the notification process for suspected and confirmed dengue cases at present? And also, when should a clinician notify, and where should these notifications to be sent?
Thank you, madam. So when a patient comes into the hospital, we notify on suspicion. So if we are suspecting that this patient can be a dengue patient, even if we do not have confirmatory evidence, it is recommended to notify this patient. Earlier we used to use the paper-based mechanism. We still do use the infectious disease notification form to notify these patients to surveillance. We also have a system called a NADSIS, which is a real-time detection system, a website, where the infection control nursing officer every day will collect the details of the patients who are admitted to that particular hospital with suspected dengue and enter it into the system. This system is accessible island-wide. It is accessible by the hospitals. It is accessible by the preventive staff. It is also accessible to the PHIs, MOHs, and the regional epidemiologists who do the preventive activities at the ground level. So they can download the data that has been uploaded by the infection control nursing officers in hospitals, and they can take the necessary preventive activities. When we consider the necessary preventive activities, what we are expecting is, if we get a patient from a certain locality and we expect that the patient has gotten the dengue illness from the residence or from the workplace or somewhere that they frequent on a regular basis. So what is expected is, once the patient is notified from the hospital, the field staff can do the preventive activities, including premise inspection, to see whether there is possible breeding sites, to see whether there is actual larvae or mosquitoes, adult mosquitoes. We also do adult mosquito surveys, and to take the necessary preventive actions, which include removing breeding sites, doing thermal fogging or UV fogging as required, and also inspecting houses or buildings within a 200-meter radius or 25 houses around the index case as resources permit. So since the mosquito has a life cycle of 7 to 10 days and a new batch of adult mosquitoes are released within that time period, the preventive actions must be taken as soon as possible. So what is advised is that once the notification is received, to do the preventive actions within 3 days. By doing this, we are trying to make sure that another cycle of mosquitoes do not get released into the environment, and that we do not have a cluster of patients where the index case was notified. So for this only, we have the real-time surveillance system. So we asked to notify on suspicion, because if we wait for the confirmatory tests to arrive, it might be too late for this action to take place. So all the MOHs, PHIs, field mosquito control assistants, all of them are working at their maximum capacity at the moment to control the current dengue outbreak. So we have also requested through the mass media and through the Ministry of Local Government and through the Glamaniladaris and everybody who is working at ground level, that premise cleaning be done by the people living in the premises, as well as locations like schools, where 40% of inspected schools have breeding places, where things like religious places, in government institutions, public places which have high, and construction sites which have high breeding indexes, to do the cleaning on a regular basis without any intervention from a health official from the preventive sector, because as a national responsibility, we can do this. Unless we do this on a daily basis as a regular habit, it will be hard to get this dengue outbreak down. Thank you.
Thank you, Dr. Bandaran, for that clear explanation. I think we as BLISI clinicians, we always our focus is on patients. We sometimes neglect this aspect. So when you walk into the ward, especially physicians, please ask the ward sister or the nurses whether you have notified the dengue patients that you are managing. I think it's important equally to get this outbreak under control.
Madam, one more thing. Since the dengue Aedes mosquito is a peridomestic mosquito, which means that you can get the mosquito breeding sites inside the houses as well as around the houses. So what we are currently seeing is that we see most breeding in discarded items like plastic yogurt cups or something. Only 1 teaspoon of liquid water is enough for them to breed for the next cycle. Also, we have to be very vigilant about our the inside of the houses, where we might have small leaks under the sink, which we don't think is a receptacle of water, but that water is enough for the breeding sites to happen. So it is very important that we also consider that in the wards as well. We might have leaking sinks, we might have ornamental flowers or like greenery that we are keeping. So unless we exchange the water on a regular basis, it might breed mosquitoes larvae. Also, just emptying that receptacle will not be enough, because the Aedes mosquito pastes the eggs on the walls of the container. So even if you empty the water and put it again, the egg will still be there. So scrubbing the interior surface is important. Thank you.
That's very important to know. Yes. So moving on, when these patients get admitted to the ward, the biggest challenge for the clinician is to detect leaking and to determine the onset of leaking. I think that is the biggest challenge we face every day when managing these patients. So my question is again to Dr. Idampiti and Dr. Vijay Vikrama. because we are largely depending on ultrasounds for detection of leaking and determine the onset of leaking. I think you both have highlighted in your presentations that it is not the case. Always there can be leaking without any ultrasound evidence. So I want you to reinforce this message to the audience today. So how are we going to detect the leaking in a patient with dengue, and how are we going to determine the onset of leaking in such a patient?
Yeah, detection of ultrasound, detection of leaking is we use three parameters. One thing is the clinically we may be able to detect clinically a pleural effusion oocytes, but of course that will be bit too late for by the time we detect, it's many hours would have gone to develop that much of effusion or oocytes. Secondly, the hematologically, when the platelet count goes below 100,000, the possibility of leaking has to be considered in any patient. Of course, now with this caseload, we rarely see patients who leak above 100,000, but with this amount of cases coming up, now we see more and more patients, probably because of the numbers, who leak even when the platelet count is a little higher than 100,000. So then the hematocrit PCV, when the PCV start rising, we have to suspect leaking. We don't have to wait for 20% rise to detect leaking. If there's 20% rise, that basically confirms leaking. That is confirmed leaking. But if it goes above by 10% and it continues to rise, then that is a fairly good indicator of plasma leakage. Then there are other clinical signs like reduction of urine output or changes of blood pressure, CRFT, and so on. But again, those might take time and depend on the degree of leaking. Then the ultrasound examination. Generally, we don't do many chest X-rays, but if you do a right lateral decubitus chest X-ray, you may be able to detect early pleural effusion. Then the focus ultrasound scan, which is done by many units now. Middle grade doctors, a lot of them are trained to do that. However, it has to be stressed upon. If a patient, especially in a patient who is dehydrated, the leaking may not be detected, even they have leaky capillaries. So when you rehydrate the patient, only the leaking will appear. So initially, if a patient comes with a platelet count of 65,000, you do the scan, it is negative. And when you give, next day you notice a lot of ascites and effusion after hydration. That happens because the patient already had leaky capillaries, so the patient had been in the leaking stage, but the degree of leaking was not enough to be detected by the ultrasound. So the absence of detection of fluid in the ultrasound does not exclude plasma leakage. So we have to take all these things, the PCV rise, the changes in vital parameters, and the ultrasound together. And also, if I may talk more about ultrasound, we have seen some patients, some in some units, some doctors have tried to manipulate the fluid quota depending on the diameter of the IVC. Checking the IVC diameter is okay if you are competent enough, but you have to take it together with other parameters, together with the clinical parameters. Now, there had been deaths where patients are not given fluid in spite of having objective reasons to give more fluid in those patients, because they thought on ultrasonically IVC was well distended. The fluid was not given. So don't sort of misguided by that fact. Don't go only by the ultrasound findings. That is the message I want to say.
At the same time, now people used to do the ultrasound and take the timing of critical phase depending on the finding of the ultrasound. So if they have like mild pericholecystic fluid and a little bit of free fluid in the scan, they take 6 hours and 10 hours, something like that. But I think it's wrong. Don't take that the amount of don't take the critical phase depending on the findings in the ultrasound. Ultrasound can confirm leakage, but it's not don't take the timing depending on the scan. So you have to take everything together: the scan, patient's clinical parameters, day of the illness, and the fever settlement. So all these things together to take the patient to the chart rather than ultrasound scan finding. So in addition, rather than doing IVC diameter, I think it's better to do the portal venous flow if we are doing the ultrasound scan. But we do that, and we can just see whether the liver is okay or not. If the patient is having a fatty liver, sometimes we can see it, but usually with dengue, I think it's not that reliable. But portal venous flow, yes, is quite good. And if the portal venous flow is quite low, so we have to hydrate the patient or give a dextran or blood or something. So that means patient is in danger.
Thank you very much. Actually, it was my next question to Professor Dastarayaka. The use of portal venous flow in the management of dengue patients. Actually, we have not included this in the guideline. I think it's an emerging area. So what are your recommendations, sir? Whether we can start using it?
No, not yet, because it's not validated in large studies. So I think it's good point to start doing it and be familiar with it. And some units have already started doing it. And for that, I think you have to know how to do Doppler. Right, so learn about Doppler, start doing it early, and then maybe publish a fairly good paper. And maybe include, you can use it then. Say so I told about ferritin. Ferritin is another useful marker, but still not validated. But I personally, in my practice, I use it. I have found it useful for prognostication. I also take discharge decisions. Usually, if the ferritin is normal throughout the stay, then they don't get worse again. So can take discharge decisions, but we can't include those in the guideline because those are not validated. So even the portal vein flow, the Damayanti told me that it works. So I have a question from some radiologists as well. They say it's looks very reliable. So what we have to do, learn doing it, and so it changes early in the illness, and even before detect gallbladder wall edema, you should be able to detect portal venous blood flow changes. Okay, then if it is very bad, reversal is very bad, the patient is at risk of getting liver ischemia. So it's going to be useful, after someone does a good study and validate it, and then we should be able to include in the next guideline. And I think it's going to be very useful. Theoretically, it should work.
Thank you, sir. So I warmly welcome Dr. Jagat Amarasekara, consultant community physician from National Dengue Control Unit. Actually, Dr. Amarasekara had been a very busy since morning because of this dengue epidemic. So he contributed to the guideline by writing certain sections. I would like to ask about hospital preparedness for this epidemic, right? So as Dr. Vijay Vikram mentioned, we might have increased number of patients in coming weeks admitting to hospitals. So how should we be prepared, and what are the facilities, infrastructure that we should have in our hospitals? Because at the end of the day, the physicians, us, should be dealing with all these problems. So what is your message to the audience?
Thank you very much, Dr. Tumita, and also thank you very much for having me in the panel discussion. As you said, there was HDC meeting chaired today by the Secretary and the DGHS, so I had to go and make a presentation there and come here. That's why I got late to come. Basically, what happens is when you have the midnight total increasing, you have so many patients in the wards. So therefore, resources, logistics get stretched. So we have to make some plans to accommodate that situation. So there was one circular also, please be aware of it. Monday, a circular has been issued by the Director General Health Service regarding what to do. There are certain areas. One thing is to have a fever corner, especially, sir, did you speak about this? Yeah, okay. Yeah. So that will give the separate the fever patients from the other patients, which will give more benefit for the other patients also who are coming for treatment, as well as get special treatment for the fever corner. Then also you can have sort of a guide for ambulatory care. I don't think everyone should get admitted, but other than the clinical side of things, the without warning signs and the platelet count and the clinical signs, you have to think of the other aspects of the patient as well. Whether the patient will be basically be compliant for our ambulatory care at home, whether they have transport to come if they have warning signs. If you consider all that, there is another guide for the ambulatory care that we can send. Then when the hospitals gets really stretched out, you can have the extra wards specifically, which are less used compared to the other wards, and get the staff to these wards from the other areas, so other of the hospital, to manage the manage the wards, but under the same consultant who's managing the dengue patient. So that is also one aspect you can think of. And then you can have logistics. Now we have the this one, the Dextra and everything is there. But I think there are some shortage of ultrasound and all for a current situation. Although we have given the requested ultrasounds earlier. So those aspects you'll have to utilize. And also if there are hospitals nearby which are having less patients, maybe you can try to get from them. But this time it's like the outbreak is in a lot of areas, so that might be a difficult task. Other option we are thinking when it gets really stretched out is to have a referral and a back referral to district hospitals, where you can send the patient there and once the patient is stabilized. So that is also one aspect that we can talk of. So these are the things. And also one important thing I think we have to think of is our staff is getting exhausted. So you can have the roster systems for even the doctors or the nursing officers, the minor staff. You can get the support from the nursing training schools. Like that, you can try to increase the human resource capacity as well. One important aspect I want to mention about preparing the hospital, when you have high number of cases, I think NHSL midnight total now it's about 90, somewhere between 90 and 100. The highest is NIID 190. Then Mathura is 180. So like that, we have a high number of cases. High viral load is there in the hospital. So that means if there's any mosquitoes biting, there's a chance the mosquito will get infected and bite the other people. So there can be spread of dengue within the staff and the nursing officers and the doctors and all the other staff. So keep your premises very clean of breeding sites, and sometimes you'll have to get the endo surveys done so that you can detect the other cryptic sites as well, and try to maintain that sort of a dengue-free zone. Otherwise, there's a very big possibility the mosquitoes can get infected and that can spread among the staff as well. Thank you.
Thank you, Dr. Amasekara. So now I think we can move on to the questions from the audience. Before I have some questions posted by our online participants. Before we move on to those, I would like to ask from the audience here whether you have any questions to get clarified from this expert panel. You can ask the questions now.
Yeah, thank you very much for allowing this opportunity to ask questions. Now, one of the key, I'm a nephrologist, so I have not been involved with managing dengue patients, but the impression I got from the initial discussions and all the case presentations made by Professor Dr. Ananda Vijayvikram is that mostly we see complicated cases due to conservative fluid administration at the moment. And whereas I think we are not seeing much complications, maybe they are not presented here, but due to fluid overload. So I just want to ask from him what is the contribution of these two extremes for under fluid administration and over administration in the current context in the management, because if the clinicians can feel that most of the complications are coming from underhydration or under volume administration, whether they can be more liberal in fluid administration. So that's my question.
Yes. Yeah, I think what we have noticed, as you could quite rightly said, more deaths and complications are due to underperfusion of these patients. It's due to many reasons, I think. When we discuss this, when in the death reviews and in other instances, what we understand is sometimes because people try to confine the amount of fluid given to the quota, they don't increase the fluid. They're trying to preserve the fluid for the latter part of the critical phase and that sort of thing. But what is necessary is when the patient is leaking, you have to give fluid. And this fluid quota has been calculated considering moderate amount of dehydration. So for a patient who has severe leaking, the patient will need more fluid than the quota. And the quota is given as a guideline only. And that's to give an idea, giving lot more than that can cause overloading, whereas less than that cause underperfusion. But it doesn't mean that you have to confine to 4,600 for each and every adult. So it varies on the clinical setting. But the biggest problem we have seen is while patients are leaking, the lower rate has been maintained. That is one of the key things. And also other issue is while giving, when a patient is having a problem, a bolus had been given and then immediately cut down to the baseline. That is another problem we have seen. And even when we are managing later, when we manage complications later, my personal view is that we can manage overload much more easily than damage liver due to underperfusion. That's what I feel.
Any other questions from the audience?
Yes, the question I got is now PCV is one of the cornerstones of management of dengue. In the clinical setting, we have seen several ways people do PCVs. Capillaries, then from venous blood. Sometimes people use a dedicated cannula to get the blood for your PCVs. I'd just like to know any experience on the pros and cons of getting the PCV. Because sometimes if you do the capillary PCV, sometimes it's slightly cumbersome as well. Sometimes it's easier to get a venous PCV from a dedicated cannula which has not been used for anything. I'd like to know the panel's experience on this.
Now, what happens is when we can use all these methods, but the thing is, now we usually take venous blood, but you can take capillary blood. But if you are taking capillary blood, then you have to do capillary blood each and every time. You can't compare venous blood with the capillary blood. So if you are taking venous blood, then we have to take venous blood. Putting a cannula will be quite easy for the patient because you don't have to prick several times. But the thing is, there can be a clot. So when you are taking the blood, so you have to keep goes under the cannula and take a little bit of blood and push it to the gauze and then see whether there are any clots. If there are no clots, then you take the next blood. Now, sometimes if a clot comes, then the value may be wrong.
And I think I agree with that. And doing capillary PCV is a cumbersome thing. And also when you're doing the capillary PCV, sometimes you get air bubbles into the tube. So collect it into the capillary tube is also difficult. So collect it from a venous blood which is collected to a bottle is much easier, and also it gives the opportunity to repeat it if necessary. Now sometimes these tubes breaks and sometimes the results we may not be very sure. So always we can repeat using the same sample if you use the venous blood. And of course we can keep a cannula. When the platelet count goes down, the chances of forming clots in the cannula is very minimal. So therefore, we can use the cannula, but as Dr. Damayan said, you have to make sure that there's no clot before collecting blood.
And at the same time, sometimes if there's a peripheral shutdown, taking peripheral blood sample may be quite difficult. And when you prick several times, all the fingers will be quite blue and then patient can't do anything. So we prefer to take venous blood rather than capillary blood.
There's a question from the online participant regarding hematocrit and PCV. What they're asking is whether there's a difference in the hematocrit in the full blood count and the PCV that we do in the ward. If we are monitoring, whether we should be like sticking to one, only the PCV if we are monitoring PCV, or whether we can use hematocrit from the full blood count along with the PCVs that we are monitoring in the ward.
No, you can't take two together if you are monitoring. Now, PCV is the best, so you have to do PCVs regularly. In one PCV is the best. But in case if you don't have PCVs, then hematocrit, you can't do one time, you can't do hematocrit and next time PCV, you can't compare because there is a variation. As I explained earlier, PCV will be a little bit higher than hematocrit. So, and the methods are completely different. So, hematocrit is just a calculated value, not the direct measurement.
Ananda, recently we noticed lots of patients while they are leaking with good urine output. So, if we stick to our 4,600 fluid quota, definitely we will be in trouble. So, sometimes the patient is in the leaking phase, they are having urine output 100, 150 cc per hour. So what is your advice and how would you advise about it?
Yeah, I think that is a very important question, especially in the present context where we see patients quite not a majority, but still a fair number who are having higher output. So again, now this, when the calculation of this 4,600, we take the maintenance. We calculate it according to the weight, but that maintenance is to compensate the urinary loss and the insensible loss. So here we have a situation where urinary loss is more than normal. So if you consider that into the calculation, their requirement will be more than 4,600. So in other words, you have to give more fluid if the output is more. So finally it will be more than 4,600. But that happens. That's not a problem. So rather than sticking to 4,600, just take it as a guide. And then depending on the patient, you have to manipulate the fluid.
Any other questions from the audience? Yes. I think Dr. Ushani Variapparumadya has a question. It's Ushan.
So sometimes you see rapid and prolonged leakers at the end of the critical phase, they are overloaded and still the output is dropping. So sometimes, what is your advice on and experience on the dextran fusimide infusion in such patients?
Giving dextran small doses during leaking can cause problems. That is the theory behind of giving a bolus. Now, recently also, there was a query from another hospital from a colleague of ours. That patient has some in the ward. I think the medical care officers have given dextran 100 ml hourly for a couple of hours. And now the patient has ended up with massive effusion and ascites. So the theory is that when you give it as a slow infusion, it can go leak out and end up resulting massive effusions or massive leaking. But at the end of the leaking phase, if the patient has reached then that the leaking has stopped, then if you want to get rid of the effusion, either you can give the dextran bolus as say 250 ml for half an hour, or if the patient is so overloaded, then if you are concerned of giving a dextran bolus, then such patients you can start on dextran fusimide infusion, but one has to make sure that the leaking has stopped. So then actually it works. So we give small dose of dextran usually about 20 ml per hour or 30 ml per hour, together with the fusimide 2 milligram or 3 milligram per hour infusion. And that works in, as you said, in patients who are overloaded with the big effusions or ascites whose output is low.
Thank you, sir. I have so many questions from the online participants. In the interest of time, I don't think we can answer all the questions, but I have picked up a couple of questions. This is to all the experts. One question is about giving the place for prophylactic antibiotics, place for prophylactic vitamin K, and place for prophylactic IV tranexamic acid when managing patients with dengue? It's a broad question, but I think it's important to answer this question because we have seen people when we have come across patients, these medications being used on patients. So I think better to answer this question.
My simple answer is no to all three. What do you think of it?
Prophylaxis antibiotics, no need actually, because dengue is a viral infection, as all of us know. So antibiotics will not answer. But if you're suspecting secondary bacterial infection, because the immunity will go down with dengue. So if the patient's fever is persisting beyond day 6, 7, or if the patient's fever has settled and another fever spike is coming, cannula site infections, UTI. So if you're suspecting something like that, then you can start antibiotics. Otherwise, there's no place for antibiotics just for dengue.
In liver involvement?
Yeah, vitamin K. If vitamin K to work, liver should be functioning. So if there is no functioning liver, we have to go for clotting factors after rota. So there's no place for vitamin K. Tranexamic acid outside menorrhagia, I don't think Ananda should be able to tell. Menorrhagia, of course, you give what outside menorrhagia.
Yeah, I think giving tranexamic acid prophylactically, I don't think has any place. Not on the IV, even oral, I don't think there's any place. We have been using tranexamic acid, of course, for menorrhagia, for even other bleeding like sometimes for gross hematuria. We have tried, but I don't know how effective that is. We have given to such patients, but commonly we use it for menorrhagia. Definitely, there is no place for IV prophylactic tranexamic acid. And the reason to start IV antibiotics prophylactically by some people is that people are concerned when the white count goes down, whether there's a possibility of having secondary infections, which is not so. This drop of white count and neutrophils is a very transient thing, so there's no risk. But as Dr. Damayan said, there are some people who can get secondary infections towards the latter part of the dengue. So starting antibiotics, not prophylactically, empirically, is okay when you are suspecting a secondary bacterial infection.
And there's one more question to Professor Dasanayaka. Is there a place for acidoxycholic acid in patients with the very high liver AST, ALT elevations in the early stages of the disease?
Not to my knowledge, no.
I think I have got more than 25 questions. In the interest of time, I think we can't take all these questions today, but I'll try my best to upload these questions and answers to our website along with today's program. So then I think all of you can log in later and go through these questions and answers. So before we wind up, our aim is to achieve 0 deaths due to dengue in Sri Lanka. So despite all these programs, awareness, still we are seeing deaths due to dengue. So my last question to the expert panel, as well as Dr. Srilada Silva is here with us, who is the chairman of Expert Dengue Death Review Committee. So if you can join us on the stage. So according to the recent death reviews, what are the main reasons for deaths still happening due to death, and how can we prevent these deaths in future? What are the precautions and what are the strategies that we should adapt when we are managing dengue patients?
Yeah, thank you, Dulya. I think we look at deaths, whether it happens during critical phase or beyond critical phase. So during critical phase, 2 things. One is underperfusion shock or unrecognized bleeding and fluid overload. But some of these things happen beyond critical phase, like fluid overload complications happen beyond critical phase. And the important thing is that and now, although we say critical phase is 48 hours, I think Dr. Ananda will explain, sometimes critical phase can go beyond that. So you have to be very careful. So at the end of the critical phase, the patient doesn't look better. We have to always think there's some complication, and you have to pick it up and address. Otherwise the patient deteriorate from that point onwards. So beyond critical phase, where basically it's a multi-organ failure, and most of the arguments during past years, whether the liver injury is due to viremia, direct viremia, or hyperperfusion, or whether the myocarditis is due to primary myocarditis, so all these, I think, are due to, in my opinion, it's due to low perfusions. Ananda, you want to explain? Because this is the misconception we have it. You want to explain it, Ananda?
Yeah, actually, as Dr. Hill, we highlighted this in our case discussions also, in some cases who are underperfused and or not given blood, who had problems and going into liver failure and finally multi-organ failure and died. So, I think that is one of the main reasons we have identified.
The point is, when you recognize there's bleeding, very often there's a delay in with giving the blood transfusions. There's a delay in, so normally about 4 to 5 hours, difficulty in getting the blood to the ward. So in that instance, I think there is a place for O negative transfusion, O negative blood. And you can discuss with the transfusion specialist in your hospital or in the closer hospital and get the opinion, because they are the people who know how to handle that type of situation, whether to give O negative blood and sometimes group specific blood, which takes little time, or the cross-match blood takes. So there have been instances where their patients are given O negative blood and recovered. Then what is your experience?
Yes, usually we should not wait hemoglobin drop, as I mentioned earlier. If we are suspecting bleeding, we have to give the blood. So we also have given on the O negative blood, and we have saved some patients. So it takes time sometimes for the cross-match, and in that case, I think O negative blood, if it's a very emergency, yes. If we don't have time to do the DT.
Yeah, just to add on that, for the death analysis also, what we have done for the analysis, I think delay by the patient is also important. Sometimes they come late. Sometimes we have found that not only the patient per se, but they have gone to few GPs and they have also not diagnosed dengue. So by the time the patient came to the hospital also, there had been some delays. In some other instances, we had to think of the compliance of the patient. So sometimes when you send the patient also, because of our economic problems and all, they start working without actually resting at home. So their condition also deteriorates. So those also things that also were highlighted. And I think few cases there was NSAIDs also given by the GPs, and the patient's condition had worsened and then they had come to the hospital. So I'm thinking beyond medical management also, other aspects also is important. If you have to achieve zero mortality, that is also important. Thank you very much.
I think we have come to the end of a very fruitful program. So we have discussed a lot of important aspects in the management of dengue, as well as where the future in the management of dengue patients. I think it is also important because as Professor Dasanayake mentioned, if we can import dengue to US or UK, we might get better evidence than what we have right now. So it's our duty to manage patients as well as generate evidence to improve our guidelines and management of these patients. So thanking all the experts who joined us today, I would like to conclude this panel discussion. And achieving zero dengue deaths is our aim. So we will be continuing this CME on dengue as a regular program. So please look forward to it. We will notify you in future how we are going to do that. And I would like to thank the National Dengue Control Unit for their continuous support for the academic programs organized by the Ceylon College of Physicians, and also for the collaboration, Sri Lanka College of Internal Medicine. Thank you for joining hands with us, because it's a very important, very challenging period where we should come together and face this dengue epidemic. So thank you all of you who have joined us on site, as well as from 17 other centers across the country. Thank you very much for your participation and enthusiasm in learning how to manage dengue patients and to minimize the deaths. Thank you.
Thank you to all our distinguished speakers for that enlightening discussion. I would now like to invite Dr. Jagat Amarasekara on stage to present our speakers with tokens of appreciation. May I invite Dr. Ananda Vijayavikrama on stage to receive his token of appreciation. This program, I would now like to invite Dr. Tilanka Bandara to deliver the vote of thanks. Over to you, Madam.
Thank you. Good afternoon, ladies and gentlemen. So as we conclude today's workshop on the critical challenges in dengue care, lessons towards zero deaths, it is my privilege to propose the vote of thanks. On behalf of the National Dengue Control Unit, I extend our sincere appreciation to everyone who contributed to making this program a success. Our heartfelt gratitude goes out to our distinguished speakers. We sincerely thank Dr. Ananda Vijayavikrama for his insightful presentation on recognizing critical warning signs in dengue patients, Dr. Damayanti Idampitiya for highlighting the life-saving importance of timely hematocrit interpretation and blood transfusion, and Professor Anuradha Dasanayaka for his valuable update on hepatic involvement in dengue and how we can use it to better treat our patients. We also thank the expert panel for their comprehensive discussion on the revised dengue management guidelines, and also the epidemiological factors, the hospital-related factors, and also for addressing the participants' questions with great clarity. Our sincere appreciation also goes out to Dr. Dumita Govindapala for expertly moderating today's panel discussion and ensuring a lively and engaging program. We gratefully acknowledge our partners, especially the Infectious Disease Forum of the Ceylon College of Physicians and the Sri Lanka College of Internal Medicine, for their invaluable collaboration in organizing this workshop and participating actively in it. A special word of thanks goes out to all the consultants, postgraduate trainees, medical officers who joined us both in person and online from across the country. Your commitment to continuous learning and improving the quality of dengue care is deeply appreciated. Finally, I wish to recognize the organizing committee, the technical team and administrative staff of the National Dengue Control Unit, the Ceylon College of Physicians and the Sri Lanka College of Internal Medicine. Your dedication and hard work behind the scenes made today's program possible. As Sri Lanka continues to face the current dengue outbreak, let us carry forward the knowledge gained today in our daily clinical practice, strengthening our collective response and improving outcomes for every patient. Thank you all for your participation and we wish you a safe journey home. Thank you.